sebe.
Rekai sebe sebe. Rekai sebe sebe. Rekai sebe sebe.
Rekai sebe sebe.
Rekai sebe sebe. Rekai sebe sebe. Rekai sebe sebe.
Mungu yu mwema.
Mungu yu mwema. Mungu yu mwema. Mungu yu mwema.
Mungu yu mwema.
Mungu yu mwema. Mungu yu mwema. Mungu yu mwema.
Niacheni cheza cheze.
Niacheni cheza cheze. Niacheni cheza cheze. Niacheni cheza cheze.
Niacheni cheza cheze.
Niacheni cheza cheze.
I
Good
believe
morning.
we can clap for NCPD choir. Kindly, thank you.
Good morning.
Morning.
Hamjambo. Habari za asubuhi. Mmelalaje? Mmeamkaje? Hivyo ndio mnasalimiwa asubuhi. Hivyo ndio mnasalimiwa asubuhi. Ama leo ndio mara ya kwanza. Karibuni sana. We are about to start. Wale ambao wako nje tunaomba muingie ili tuweze kuanza. Karibuni. Kindly. Hello, hello. Those who are outside, please come in so that we can start. NCPD choir, endeleeni kututumbuiza.
tusiogope, changamoto ni tosha, kujifunza, serikali inawajali, ndiyo silaha ya kweli. Vijana tuanzishe miradi tuijenge, taifa letu mbele. Vijana tuamke, wakati ni sasa, tunayo nyota, tusiogope, changamoto ni tosha, kujifunza, ndiyo silaha ya kweli. Vijana tuanzishe miradi tuijenge, taifa letu mbele. Vijana tuamke, wakati ni sasa. Vijana tuanzishe miradi tuijenge, taifa letu mbele. Vijana tuamke, wakati ni sasa. Tunayo nyota, vijana tuanzishe miradi tuijenge, taifa letu mbele. Vijana tuamke, wakati ni sasa. Wakati ni sasa. Tunajivunia Kenya nchi yetu, kweli yapendeza, kweli yavutia. Tunajivunia Kenya nchi yetu, kweli yapendeza, kweli yavutia. Nitailinda maishani mwangu. Tazama porini, simama nguruma, kifaru yu pale na ndege wa anga. Tazama porini, simama nguruma, kifaru yu pale na ndege wa anga. Nitailinda maishani mwangu. Ziwa la Bogoria kweli lashangaza, majini ya moto, hiyo ni ajabu. Ziwa la Bogoria kweli lashangaza, majini ya moto, hiyo ni ajabu. Nitailinda maishani mwangu.
Asante sana NCPD Choir. Good morning. Good morning. Distinguished guests, government representatives, development partners, ladies and gentlemen. It is my great pleasure to stand here before you in this launch of the Her Health Project. Asanteni sana kwa kufika kwa wakati. Tumeanza mapema kadri ya vile ambavyo tulitarajia. but it is always good to start earlier than later. Sindio? Haya. Before we start, my name is Mashirima Kapombe. I am a journalist with Citizen TV Kenya, but for today I stand here as your MC. And before we proceed, I would like to invite us to a brief moment of reflection. I would like us to think about one young woman. Just one, not two. You can close your eyes or not. She could be your sister, your niece, your daughter, your neighbor. Just one young woman whose story has stayed with you. One whose future could be transformed when they have access to sexual and reproductive health care services. Can you see her? Can you see her? Now that is who this launch is for. That is why we are here today. Because so many young women across Kenya are struggling to get these services, quality services. But today we are here because of partnership, because of collaboration. We are here to strengthen systems. And because of that, we want to formally set the tone for today's proceedings. And we want to do that through prayers and the national anthem. So I'd like to call onto the stage Adelaide Maina and Aden Ibrahim to lead us in prayers. Adelaide? Adelaide is here. Sawa sawa.
Good morning, everyone. Good morning. Good morning. See, we have life. Imagine God has blessed us with life today. So when we say amen, we are just acknowledging His presence in our lives. So I say again, good morning.
Good morning.
Praise God.
Amen.
God is good and all the time. I will request that we stand for a word of prayer. Let us pray. Almighty and loving Father, in the precious name of Jesus, we come before you this morning. Lord, we want to acknowledge you alone is God. We want to say thank you for the gift of life. Thank you for giving us a new day in our lives. And thank you, Lord, for this moment that you have given unto us. Father, we have converged here because you gave us an idea. And I want to thank you that, God, today you are helping us to realize that idea, O Lord. And I want to thank you, Jehovah God, for RHNK in collaboration with NCPD. Father, Lord, I want to say thank you for these two organizations. Thank you because you love us so much that you saw it fit that we be the people who are going to make this idea be realized. And I will thank you for our guests today who have come so that they can be part of this project, oh God. Father, Lord, I want to welcome you at the center of this event, even as we start, oh Lord, as we discuss, as we inform each other. Jehovah, Lord, I pray that may your Holy Spirit be amongst us. May he be the chair of this event, and may he guide us through according to your will, O God. Remove that which is ours and fill us with your wisdom, O God, that whatever we are going to discuss, whatever we are going to agree on, O God, it will be in accordance to your will upon our lives, O Father. Thank you for the Her Health Project. Father, Lord, we know that it is going to be beneficial to our people, to our women and girls. Father, Lord, I pray that Jehovah, Father, may you make it a success, even as we start it, oh Lord. May you, Jehovah, Lord, bless your blessings upon each and every person who is going to participate in this project. May your will be done, even as we start, as we move on, and as we end. In Jesus' name, I pray and give thanks. Amen.
Aden Ibrahim. Halima will do it. Karibu Halim.
Thank you so much. Bismillahir Rahmanir Rahim. In the name of Allah, the most gracious, the most merciful, All praise is due to Allah, Lord of the worlds, the most gracious, the most merciful, Master of the day of judgment. You alone we worship, and you alone we ask for help. Guide us on the straight path, the path of those upon whom you have bestowed favor, not of those who have earned your anger, nor of those who go astray. Amen.
Amen. And now for the national anthem and the East African anthem. Thank you, NCPD Choir. Asanteni sana. You may now take your seats. A round of applause to the NCPD Choir. And to officially welcome us and share opening reflections, it is my pleasure now to invite the Director General of the National Council for Population and Development, Dr. Mohamed Sheikh, to welcome us and share opening reflections. Karibu sana, Daktari.
Good morning. Hello, good morning. Working? Great. Our chief guest, the Director General for the Ministry of Health, Dr. Patrick Amot, Nelly, the CEO of RHNK, UNAID representative, Dr. Richard, Mayor, colleagues, friends, good morning. First and foremost, I want to take this opportunity to welcome you all to this very wonderful event, an event that we are going to look at issues to do with women and maternal health matters. My name is Dr. Mohamed Abdikadir Sheikh, the Director General for the National Council for Population and Development. I just want to, first and foremost, because of changes in our program, our chief guest has also other engagements. We will start the program off, but then later we will also have other remarks after that. Mine is just, first and foremost, to take this initiative to invite you to this function, but also just give you a reflection as to why I'm here this morning. Before arriving here this morning, I was reflecting on what to speak about. I want to tell you one time when I was acquired there by the government. So I was posted there. I thought, what am I going to do there? And I went to a newly created district. As a district medical officer, I was the med soup, I was the district medical officer, I was everything. My experience in that area has always remained in my mind. I witnessed in first hand, the quiet struggles of women and young women especially seeking reproductive health services and maternal health services. Ijara is around 11,000 kilometers square It borders Tana River. So on that side of Ijara at that time, we had no theater and we had no anesthetist. So what happens whenever there is any maternal complications, especially obstructions, hemorrhages, I will take an ambulance, transport the mother from Masalani Hospital, bring to the river banks of Tana River. The river is a very big river. I will talk to the MOH on the other side. He will also bring an ambulance, and then we take a boat with that mother who is bleeding, who is obstructed, and then cross with that mother, take her to that side of the river, take her with ambulance, and take her to the theater. And then after we are done with the cesarean section, whatever procedure, then it was my time again to bring back to my hospital, because I had to take care again in my hospital. So that one really always remained in my mind. And that's why sometimes when we talk about maternal health, I always say it is issues to do with accountability. Because we can take anything else, everything is there in those facilities, in those counties, but then what we lack is those basic things. Northern Kenya, just like other counties where distance, stigma, and harmful cultural practices continue to shape their daily life, many girls will arrive in the facilities late, often after complications had already set in, especially somewhere barely, teenagers, pregnant mothers navigating pregnancy in silence. Others fear judgment more than illness. I saw how limited access to, maternal health services, how, low school retention and early marriages intersect to deny them social choices and opportunities. Those experiences did not just inform my clinical judgments, they shaped my conviction that systems must be responsive, respectful, and accessible. A health system must meet a girl where she is, without stigma, without delay, and without compromising her dignity. That's why today the launch of her health project is particularly special for me. Every girl in Kenya today needs a system that works for her, a system that addresses her health without compromising who she is or where she comes from, a system that does not ask her to choose between school and seeking care. In these counties of Samburu, West Pokot, Garissa, Tana River, and Homa Bay, girls face persistent inequalities, which include inadequate access to quality healthcare services, inequalities in education, inequalities reinforced by harmful cultural practices and poverty. At the National Council for Population and Development, our mandate is to provide policy and leadership on population and development. Our mandate is also to coordinate the implementation of the population policy and to ensure that demographic dynamics are aligned to the sustainable national goals. Kenya demographic dividend depends on how we support our adolescents today for a better tomorrow. The Kenya National Population Policy for Sustainable Development reminds us that fertility is central to population dynamics, and adolescent fertility in particular undermines social economic growth. Further, teenage pregnancy leads to school dropouts and fuels intergenerational poverty, which results to the lost productivity and weakening of national development. Esteemed ladies and gentlemen, our chief guest, in these 5 counties, adolescent girls face systematic high rates of teenage pregnancy, maternal complications, deaths, new HIV infections, sexual and gender-based violence, and unmet need for family planning. That's why the Her Health Kenya project is designed as a long-term government-aligned reform. It's not a short-term intervention, it's a system reform transformation efforts. To ensure the right trajectory, the initiative was consultative and deliberate. It was developed in a close collaboration with the Ministry of Health, particularly the Division of Reproductive Health and Maternal Health, in partnership with the county government and key stakeholders. And why? Because sustainability requires ownership requires alignment, and alignment requires coordination. I'm happy to note that this approach directly supports the key results areas of NCPD. 1, first, policy leadership and advocacy so as to strengthen policies that address adolescent fertility and reproductive health while aligning county development plans with national population priorities. Second, coordination and partnership. We are convening government, civil society, development partners, and the private sector to work within our coherent framework. And third, research, data, and evidence-based planning. We are strengthening the use of data to guide investment and track progress. We are also ensuring that decisions are driven by evidence and not by assumptions. Fourth, resource mobilization and sustainability. In time of declining partners funding, we are intensifying domestic resource mobilization and innovative financing approach to protect gains that we have made as a government. These 4 result areas directly align with our strategic goals of strengthening national and a county system that delivers sexual, reproductive health, and maternal health services, improve access to youth-friendly information and services, contribute to measurable reductions in maternal mortality and morbidity. Last year, through our partnership with the United Nations Population Fund, we launched what we call the Women X Initiative, amplifying women's leadership and accelerating progress in reproductive health and gender equality across Africa, with Kenya as focal point. So Kenya is the hub for the Women X, and this was launched in Aga Khan Hospital. I wish to sincerely thank the Reproductive Health Network for partnering with NCP on these bold reforms. This collaboration and commitment demonstrate trust in government systems and reflects confidence in national ownership. Let's remember, when a girl can access care without stigma and stays healthy, she stays in school. When she stays in school, she builds her future. And when she builds her future, she strengthens our national development. Thank you. And at this juncture, I want to take this opportunity to welcome our Director General for the Ministry of Health, also to make his remarks. But asanteni sana na Mungu awabariki. DJ karibu. I know you are, this one is not for you.
It is pediatric, but it's still growing up. Thank you. Thank you, Dr. Sheikh, the Executive Director of RNHK, Nelly, Dr. Sheikh of NCPD, colleagues from UNAIDS, Ministry of Health, and other partners. Ladies and gentlemen, good morning. It gives me great pleasure to join you today at the launch of our health project, targeting 5 counties, carefully selected based on critical indicators showing different levels of performance. This launch here today is not a mere PR exercise, but is an entry point into how we build a fully functional health system that is responsive to the needs of our people. We all know that our population is fairly youthful, and therefore, if we invest in the young people, then we will be able to achieve demographic dividend. If we ensure that they go to school, they acquire the right skills, we have the proper governance structures, we empower them economically, that is the way we can be able to move from our current status to an upper middle income country. Therefore, this investment that is jointly spearheaded by the Ministry of Health, NCPD under the National Treasury, and RNHK then is the right investment to be able to make. I also want to emphasize that this launch comes at a very critical time when you're having a national discourse on maternal and newborn health. It is just about 2 days ago at Serena Hotel when we launched the MPDSR, Maternal Perinatal Death Surveillance and Response National Committee on tracking maternal deaths. And this is one of the key pillars of the leadership reform and accountability frameworks that we need to do to be able to ensure that women, girls, and our children not only survive but thrive to be able to achieve their full potential to help us power this country to the next level. We have done MPDSR before, but the R in it has been silent. The P has also been silent. As a country, we have never focused on perinatal deaths. We treat them like they are little deaths. And also the response of it, the interventions that we make after the audit that should be able to save the next life, then have not been key areas of focus. So launching the MPDSR then was critical to ensure that we can be able to account for all deaths, not just as mere numbers, because behind those deaths are families devastated, husbands widowed, children orphaned, and therefore we don't want to treat this as mere statistics, but as critical lessons learned that can then be able to save the next life. We are also, as a ministry, in the process of starting a Rapid Results Initiative, an RRI, on reducing maternal mortality in the 26 counties with the highest burden of maternal mortality. If you look at the pattern of maternal mortality in this country, the national figures then mask the regional disparities or the inequities which have persisted ever since we got independence. We are now going to zero on the 26 counties with a 60% burden of maternal mortality, to be able to clearly put interventions in place that can make us move the needle a little bit to be able to reduce the maternal mortality ratio as the clock ticks towards 2030, a mere 4 years away. And we believe that with the investments that we have made in this ecospace in the last 10, 15, 20 years, then we should be at par with our regional neighbors. If you look at MMR for the United Republic of Tanzania, it's much lower than what is quoted in Kenya. If you look at Uganda, Rwanda, and our figure that we have of 355 is a figure of the KDHS 2019. And you know KDHS is a retrospective data. So those are figures of 2013, 2014. As a result, as a ministry, we have been directed to be able to conduct a reproductive age mortality survey in Ramos, which is a very scientific way of determining how many mothers we lose in a year. We are going to do this in consultation with our premier research institution, KEMRI, and we have submitted our proposal for ethical approval at the KNH, University of Nairobi Ethical Review Board. We are hopeful that in the next 6 weeks we'll be able to get the approval and commence on the data collection, and therefore thereafter we shall be able to have a data that we can be able to stand up to and say this is the true reflection of maternal health in this country. We want to do it as scientifically as possible, and that is why we have decided to follow that process. It will take a bit of time, but we want a credible result that can also be accepted by the rest of the global community. Further to that is that we are going to launch the Ewene, every woman, every newborn, everywhere. After we have had this discussion with the 26 counties, we are going to launch this national program, which is going to be a whole of nation, whole of society discussion on maternal newborn child health. The progress that we have made, I've said, is uneven. In terms of child health data, better progress compared to maternal data, because if you look at the Kenya Demographic Health Survey of 2022, our children under 1 year, 7 out of 10 of them will live to see their first birthday. And under 5, 6 out of 10 children born in Kenya will be able to live to see their 5th birthday. And of course, 8 out of 10 newborn babies live to see the first month. Despite those good statistics which we can be able to improve on, we still have the burden of high teenage pregnancy, and that is the rationale of selection of some of the counties. In the KDHS 2022, Samburu County had a teenage pregnancy of 50%. So if you went to Samburu County and sampled all the adolescents in Samburu, half of them would be pregnant. And pregnancy means that that girl will not be able to complete school probably, will never be able to achieve her full potential, and enters that vicious circle of poverty. Because teenage pregnancy most likely will get another pregnancy there soon thereafter because of lack of information, may not be able to access contraception, has a high risk of acquiring HIV, likely to suffer sexual gender-based violence because she does not have full autonomy to be able to decide for herself. Then the unmet need for family planning is also another challenge that we are dealing with. This is happening at a time when we are having a shift in the overseas development assistance. The policy statements made by the Global North the nationalism in the global north, where they want to invest more of their money, 5% of their GDP in security, and the funding cuts to various agencies, including WHO, UNFPA, then poses a threat to our critical programs, including family planning program. We are proud as a country that our family planning program, which we established in the 60s, is one of the most successful in this region. And we had achieved significant progress. Our modern CPR was about 57% in KDHS 2022. And therefore, what we are doing currently is to be able to have a discussion. It is only yesterday and last week that we are meeting the Parliamentary Health Committee to be able to discuss the budget policy statement. And we are appealing for ring-fencing for resources for some of these critical programs, including family planning, HIV, TB, malaria, immunization, amongst others. We have had a success, especially with immunization, and we believe that we'll be able to convince them to be able to ring-fence resources for these critical programs so that they're not subject to the budget rationalization that takes place periodically. If we come to the space of HIV, we have also talked about the triple threat of teenage pregnancy, HIV, and sexual gender-based violence. Again, the critical drivers of HIV now, adolescents play a critical role. Nearly a third of the new HIV infections in our ecospace happen in adolescents and young people aged 15 to 24 years. So, and unfortunately, this same group then have the least knowledge about HIV transmission and acquisition. Maybe we as policymakers are the ones who are failing, because then these people are very active in the social media space. Maybe we need to be able to reconfigure and recalibrate our information communication to them so that we can be able to reach them in their places of comfort. I think this is one of the things that this particular project will try to be able to address as part of the advocacy. As a country also, we are undergoing an epidemiological transition. For a long time, the global south has been known as the area or the region of communicable diseases, the choleras of this world, Ebola of this world, while the other diseases were known to be for the global north. But now we are catching up. Our burden of NCDs is estimated to outpace communicable diseases again by 2030. And you know, most of the NCDs are long life conditions. Therefore, in terms of our planning and our resource allocation, we must be able to think a little bit differently. That this is not going to be like cholera, where you have an outbreak, we can close the eateries, we can be able to put hand stations, we can chlorinate the water, and in 2 or 3 days we are done with that problem. If I'm diagnosed today with diabetes and our life expectancy has improved, I will live another 20 years with that diabetes. So we need to be able to plan for me in terms of my healthcare needs and the potential complications that will arise out of my condition. And this is basically being driven by our habits. Now we are eating more ultra-processed foods. It is gisty to be able to eat pizza than eat managu. We live a sedentary lifestyle. Even if I want to go to KNH, I'll hop into a border from here and pay 50 bob rather than just walk. We take lots of sweetened beverages, alcohol, tobacco consumption, name it. And therefore, as we do this, I think this is one of the key things that you need to embed in this program so that we can be able to inculcate good health behavior so that we can be able to avoid some of these conditions. As a country, in terms of delivery of universal health coverage under the bottom-up economic transformation agenda, premised on 4 key pillars of health workforce development, commodity security, domestic manufacturing of local health products and technologies, including these critical ones that we are saying that we are going to ring fence. It would be very easy to ring fence, but the budget for immunization, if you are able to manufacture our vaccines here. Very easy to do so if you are to manufacture family planning products here, and HIV antiretrovirals also. So we are trying to really focus on that pipeline for commodity security to ensure that through local manufacturing, then they can be able to reduce the cost of healthcare provision. We are going digital integrated health management information system. Now under SHA, if you look at the deliveries that have taken place under SHA from October 2024 to January 2025, which is about 1 million mothers. We know those mothers by name, by their ID numbers, by the facilities they delivered in, and the outcomes of those deliveries. So we are aspiring to be a country that will be one of those first countries in the global south, not to do the periodic surveys, but to be able to get data real time as our people seek healthcare services. And finally, of course, is the health financing key. I think that should be the first one because it's the departure from NHIF to Social Health Authority. I know we had a small problem initially with the level 2, level 3 facilities, and we have provided a professional opinion on that, and that has been changed. Now the mothers who are delivering level 2, level 3 facilities will have their costs totally reimbursed by Social Health Authority. So these investments together will spur us as a country to be able to reduce that vicious circle of poverty and spur economic development and catapult us as a nation into the next sphere of nations, which is the upper middle income status and eventually high income status. I want to assure you of our support in the implementation of these projects together with our counties, partners, together. As a people, as a ministry, as a government, we cannot be able to do all this alone, and that is why partnership is critical. And we appreciate the support from Reproductive Health Network, partnering with NCPD, which is a sister institution to the Ministry of Health and the county governments to be able to move the needle. We are at that particular point in time where the decisions we make will mean more mothers, more adolescents, more young women, more children survive. And we can be able to do it. 4 years is sufficient time enough for us to be able to make real progress and demonstrate to the rest of the world that with political commitment, working together with various partners, then we can all make a difference. With all those very many remarks, I want to declare your meeting officially open. I wish you fruitful deliberations. Thank you.
Thank you, Dr. Amoth, for your leadership and for reminding us of the importance of strengthening systems. Now we will now hear from our host and partners whose collaboration continues to make this initiative possible. Okay. We take a short break to allow the DG to leave. Then we will be right back. NCPD Choir, kindly take the stage for brief entertainment. NCPD Choir. And as they make their way to the stage, we can reflect on what the DG has talked about, right? Can we do that? When we started, I asked us to just briefly think about that one young woman. Did you think of her? So we'd also like to recognize the presence of county commissioners who are here with us. Karibuni sana. Thank you for making time. As we said, this launch will happen in 3 counties. The Her Health project will be happening in 5 counties, that is Garissa, Tana River, Samburu, Homa Bay, and West Pokot. And as Dr. Mohamed Sheikh said, it's about ownership, alignment, collaboration, and strengthening systems. Sindio? So that it works for her, our adolescent and young women, so that they can have access to quality sexual, reproductive, and maternal health. Karibuni sana kwaya.
You can join us for this song.
Tushangilie Kenya, taifa letu tukufu, Kenya tunayoipenda daima, Kenya nchi tunayoipenda daima, Kenya nchi tunayoipenda daima. Tujivunie sana tukijiita wa Kenya, nchi yenye baraka daima. Hatutaacha Kenya daima na milele.
Asanteni sana NCPD Choir. Tuwapigie makofi tafadhali. Surely, is that the best you can do? Asante sana. And as we continue with our program of the Her Health Project launch, which has already officially been launched by Dr. Amoth, I would like to recognize the presence of county representatives from the 5 counties where this project will be taking place. That's Garissa, Tana River, Samburu, Homa Bay, and West Pokot. Kama uko hapa na unawakilisha county, kati ya county hizo 5, kindly stand up so that we can be able to give you the mic, introduce yourself, and let us know who you are. Wacha tuanzie hapa.
Good morning. I'm Fatuma Isa, County Reproductive Health Coordinator, Garissa.
Good morning. Adin, County Director Health, Garissa. Thank you.
Good morning. I'm David Saruni, the County Commissioner, West Pokot. Thank you.
Good morning. I'm Joseph Mwangi, County Commissioner, Tana River.
Good morning. I'm Udongo Apollo, Homa Bay County AYP focal person.
Good morning, everyone. I'm Madawa Jacob, County Reproductive Health, Homa Bay.
Good morning, everyone.
Good morning.
I'm Grace Karaoke, representing the County Commissioner, Homa Bay. Thank you.
Good morning, everyone.
Good morning.
My name is Nancy Chebet, for Director Health, West Pokot County, and it's a pleasure being here. Thank you.
Good morning, all. I'm Agnes Cherotich, Adolescent Young People Lead, West Pokot County.
Good morning, everyone. Consolata Sire, I coordinate reproductive health, West Pokot County. Thank you.
Habari zenu.
Nzuri.
I'm Lucy Nabura Hiribai, coordinating reproductive services in Tana River County.
Asante sana.
Good morning, everyone. I'm Samuel Mwangi, representing CC County Commissioner, Samburu County.
Thank you so much. We also have in our midst NCPD Regional County Reproductive Coordinator for Health. We also have County Directors of Health, Adolescent Youth Focal Point. Karibuni sana. And I want to hear from our hosts and partners whose collaboration to make this initiative possible. And we now welcome on stage Ms. Nelly Munyasia, the Executive Director, Reproductive Health Network, Kenya. Tumpigie makofi.
Sorry. Thank you so much. Dr. Bashir Isaac, Head of Family Health. Dr. Mohamed Sheikh, Director General, NCPD. Dr. Jackie, Head of Adolescent and Youth at the Ministry of Health. UNAIDS Country Representative. IPPF Representative. RHNK Board. I see Madam Evelyn Opondo, and I saw Madam Beverly Paulette somewhere. It's important that I recognize them so that I'm not fired after this meeting. And then I also see our development partners, Netherlands, represented by Dr. Kuya, SIF, represented by Dr. Job. I see my fellow representatives, my fellow CEOs from civil society organizations. I have co-CEO of Luala that you'll be hearing from in a while. I see Dr. Kitui from IPAS. And my fellow CEOs, if I've not mentioned you, forgive me, I recognize you, I see you. Representatives from civil society organizations, our young people that today we also are celebrating and planning for, and anyone else that I have not mentioned. Good morning. Good morning. Good morning.
Today is an exciting day. Forgive me, I need to recognize our partner in this business. RHNK is not implementing this initiative alone. Of course, under the leadership of the Ministry of Health and National Council for Population and Development, we are implementing this with the Center for Reproductive Rights that has been a partner for RHNK for more than a decade. I recognize you, and I know you'll also be providing remarks after me. So in Kenya today, too many girls begin motherhood before they are ready. According to national data, nearly 1 in 5 adolescent girls aged between 15 and 19 have begun childbearing, and the Director General actually alluded to that. In some of the counties we are working in, Samburu, West Pokot, Tana River, the number is even higher. And those are just not numbers. Those are our daughters, those are our sisters, and those are people that we want them to, become better people in the community. But statistics do not carry babies. Statistics do not drop out of school. Statistics do not sit in maternity rooms, afraid and alone. Behind the statistic is a real girl. A girl who left school before her dreams had a chance to grow. A girl who didn't receive accurate, age-appropriate information about her own body. A girl who gathered the courage to seek help only to face stigma at a health facility. A girl who walked for quite a long distance, and we heard Dr. Sheikh say that it's quite heartbreaking to imagine that you have to cross a river, you're bleeding, and you can imagine that's the true story of what is happening in some of these counties that we intend to work in. And also, as they go to the facility, they had to wait for long hours only to be told, come back next week, we are out of supplies. And those are the realities. A girl who left school before her dreams had a chance to grow. A girl who didn't receive accurate information about her own body. A girl who gathered the courage to seek help only to face stigma at a health facility. A girl who, and when her story becomes public, we then ask, why didn't she know better? Why didn't she wait? How could she know better when we have failed as a society? How could she wait when there was nothing to wait? Rarely do we ask, where did the system fail her? And that's why we are gathered here today, ladies and gentlemen. Who is to blame for what happened to her? Because when a girl becomes a mother before she's ready, it is not simply a personal choice. It is often the result of gaps in education, barriers in healthcare, silence in our communities, and policies that do not reach the very girl who need them most. And we know how our communities have enabled this because of the culture, because of our societal norms that have perpetrated this for over years. The data from our secondary analysis tells us that we already feel it in our hearts, but now we can no longer ignore. It is time for us to act. From the fact sheet, these are just not numbers, and I'm sure you all have had the privilege of having a look at the fact sheets we've put in your folders. These are system failures dressed up as statistics. And the consequences, they are borne by girls whose potential we are letting slip away. One missed clinic visit, one stock out, one judgmental provider at a time leads to unbearable consequences in future. But today, as we launch this initiative, and we really don't want to call it a project. It is an initiative led by government because it has to be sustained. It has to go beyond, 3 years, 4 years. We have taken a bold step with our funders and people that have invested in this for us to look at it long term, 7 years. A lot of times we'll be told it's not doable, but 3 years, 2 years, it's not enough time for us to measure impact of an initiative. And so this is not a project. Please delete the word project and look at it as an initiative. We are choosing to ask better questions and build better answers. We are choosing to ensure that every girl has access to accurate information, that every health facility becomes a place of dignity, not judgment. That distance, cost, and stigma no longer stand between a girl and the care she deserves. This is not a project, it is a reckoning with the governance barriers that keep counties voiceless in national policy, even as they deliver on the care as front lines. And that is why we are very intentional in even introducing county representatives today, because they'll be at the center of changing this story. A reckoning with the financing gaps that create stockouts of contraceptive commodities, not because we lack the funds, but because procurement systems are too slow, too fragmented, too broken. And I think listening to the DG today, early this morning, DG Health, there's some hope. We can see there is intentionality, there's the initiative of even engaging the parliamentary in charge of health, so that we can see, are they able to allocate funding so that we do not continue to see the issues, with stockouts and everything else. A reckoning with service delivery failures that leave girls traveling for hours to reach a health worker who may or may not have the training, the tools, or the time to help her. And yes, a reckoning that the silence that surrounds adolescent sexual and reproductive health, the silence in schools, the silence in homes, the silence in policy rooms where girls are discussed as problems to be managed rather than people whose rights must be protected. Today, we are breaking the silence. The Her Health initiative is not about us. It's not about the civil society organizations. It's not about the donors. Neither is it about the government in the room. It is about that girl. The 16-year-old in Samburu who knows she wants to finish school, but she doesn't know where to get contraception without family finding out. The 18-year-old in Garissa who has heard rumors about HIV, but has never been taught the facts, now fears seeking an HIV test because she doesn't know what comes next and how to handle if the results turn otherwise. The 17-year-old in West Pokot who walked 3 hours to a clinic only to be told that implants are out of stock and to come back maybe next month, and that next month might never come. She is why we are here, ladies and gentlemen. Over the next 5 years, we will work together to build systems that work for her. Not parallel systems, not donor-driven vertical programs that disappear when funding dries up, but government-led, county-owned, community-rooted systems that are resilient, accountable, and built to last. To the leadership, Dr. Bashir, and all the policymakers in the room and county leaders here today, we are grateful for your leadership. We take note that there's the intentionality from government to prioritize maternal health in this country, but importantly to also prioritize adolescent and youth. And we continue to call on you to hold firm to your commitments, not just in words, but in budget lines, in policy reform, and in oversight. To our development partners, thank you for believing in this vision. Stay with us for the long haul, because systems take time. And you'll be listening from some of the partners that have gone before us in trying to take on a similar initiative. And you realize system change does not take 2 years, it doesn't take 3 years. Even at the 4th year, we might realize that we are on the wrong route and we need to start all over again. Please, development partners, be patient with us, invest in this, because the government leadership is taking lead on this. And to the civil society organizations, health workers, and community advocates, you are the backbone of this work. Without you, no policy will reach the ground. No policy will reach the beneficiaries. They will not be able to hold government accountable and ask them the difficult questions. And to the young women in the room and across Kenya, this project is yours. We will listen, we will follow your lead, and we will not rest until the health system treats you better and with dignity that you so much deserve. Let us be the generation that stops asking why she failed and starts building a system that refuses to build the girl. Let us be the generation that transforms. Let's make the hashtag systems that work for her a lived reality. Thank you so much.
Thank you so much, Nelly. Nelly has painted such a vivid picture, right? If you hadn't seen her when you were having your reflection, I think you can now see that girl, right? And that young woman for whom this project is for. And I like that she says it's not a project, it's an initiative. Asante sana Nelly. Let's now move forward and invite Ms. Salima Nabusobia, the Vice President from the Center for Reproductive Rights Africa. Karibu sana. Tumpigie makofi.
Good morning. I am not an imposter. I am not Salima. I am here to represent Salima Namusobia, who is our Vice President for the Center for Reproductive Rights. My real name is Elsie Saina. I am the Associate Director for Advocacy and External Relations at the Center for Reproductive Rights. So thank you so much, Nelly. Thank you so much, colleagues. And I will be reading her remarks on behalf of the center. I really like what Nelly says. This is an initiative, not a project. And I would say that indeed a journey of 1,000 miles begins with one step. And I'll start with a little story. Allow me to deviate a little bit. Of an experience I had talking to a young man one day, asking him why was he interested in working in our field of working with adolescents. And he told me that one day he went to school, he had a very close friend who sat next to his desk, and one day the friend never showed up. They used to always work together, and this friend was an adolescent girl. And he was so depressed and upset that he went to find out what happened to her. He went to her home. And it turned out that he found that she was pregnant and was ashamed to come to school. And I'm glad that this initiative targets those kinds of girls out there that really need to be empowered, and the systems, including the fact that the government is taking this very seriously. So allow me to adapt the protocols by Nelly and start the remarks on behalf of Salima. Ladies and gentlemen, distinguished guests, all protocols observed. On behalf of the Center for Reproductive Rights, it is my profound honor to join you as we launch High Health Initiative. The Center's Africa program has been building expertise in our region since 1997. We opened our regional office in 2001. Our mission is to ensure that everyone has a right to make decisions about their own reproductive health and to access quality reproductive health services without discrimination or coercion. As we work towards this, we use different strategies, building partnerships with both state and non-state actors. For over 15 years, the Center for Reproductive Rights has advanced sexual, reproductive, and maternal health rights for women and girls, not only in Kenya, but also in the region. Our focus has been advancing maternal health rights and in line with our constitutional imperatives. We do this by deploying legal and advocacy strategies. As an example of our work on protecting women from obstetric violence and promoting dignified maternal health care resulted in a landmark decision of the Court of Appeal in February 2024, affirming the right to respectful maternal health care in the case of Josephine Majani, who had been denied quality and respectful maternal care. In furtherance of our work on maternal health and adolescent sexual and reproductive rights, the Center, in collaboration with our partner, Reproductive Health Network of Kenya, and with the support of Co-Impact, we've embarked on this project to ensure that our journey in designing interventions truly address the systemic barriers that impede adolescent girls' access to quality reproductive health, information, and maternal health services and rights. This partnership has stemmed from the urgent need to address the legal, social, and other systemic challenges that negatively affect adolescents. And our DG was very clear this morning about outlining some of the challenges, and we are excited that we are indeed partnering with the government to ensure that we begin to address the systemic barriers. Kenya, particularly in the rural areas, have very high levels of, again, teenage pregnancies, we were told. Nelly mentioned this, and this is the reason why we are putting at the center of our project are these adolescent girls that I mentioned at my story at the beginning of the remarks. Speaking to what we have done as our journey, what led us to come here today with the RHNK, our implementing partner in this project. We believe in achieving a people-centered outcomes and strengthening government systems to ensure sustainability. The strategy that we will deploy in this initiative will ensure that it is indeed state-anchored. Interventions are more likely to endure beyond the initiatives of the state actors, non-state actors. Indeed, while NGOs often face limitations to reach due to funding, capacity constraints, government system processes, infrastructure, we believe that we will continue to ensure that we still put at the center a voice of marginalized communities, including our adolescent girls. In line with this approach, we collaborate with RHNK. We have a shared vision, which is all adolescents living in rural and marginalized counties in Kenya will have access to quality sexual, reproductive, and maternal health services. We appreciate that the primary focus of this intervention is strengthening the health systems. We recognize that achieving sustainable and impactful change requires a multi-sectoral approach, which includes active involvement from our justice sectors and legislature. And this is the value add of the Center for Reproductive Rights. We have looked and we are very clear that the justice system ensures implementation of existing laws and policies, provide authoritative interpretation of laws related to sexual, reproductive, and maternal health rights, including remedies for violations when they occur, and ensure accountability. The legislature, on the other hand, is mandated to develop and enact laws and policies that make it relevant to ensure that the existing laws are allocated enough as resources, but also have meaningful impact for the intended beneficiaries. Together, they create an enabling environment that supports the health system to ensure it delivers equitable, comprehensive, rights-based sexual and reproductive maternal health services to the adolescent girls. Noting this critical role that both the justice system and the legal sector play in advancing the sexual, reproductive, and maternal health, the Center, together with our partner RHNK, shall be deepening our collaboration with key stakeholders, including the judiciary. Our partnership with the Kenya Judiciary Academy and the International Association of Women Judges in Kenya will go a long way to ensuring that we realize the systems change that we envisage in this initiative, not project. We shall also be collaborating with our parliament partners to ensure that the laws and policies that really do affect the beneficiaries will be able to comply with our constitutional imperatives. In conclusion, allow me to sincerely thank you all for coming in today to partner with us in this wonderful launch. We're thankful to our partners RHNK, the NCPD, and all the staff that work so closely to putting this together to ensure it is a success. Thank you for your partnership, thank you for your commitment, and as the Center, we commit to lending our expertise, our passion, our support to realizing the impact and the outcomes of this impactful initiative. Thank you so much once again. We appreciate and thank you for coming to join us today. Signed, Salima Namusobia, Vice President, Africa. Thank you so much.
Thank you, Elsie. And we would have liked to have lawmakers here to give their remarks. Dr. James Nyikal, Chairperson, Departmental Committee on Health, National Assembly, would have loved to be with us today, but because of unavoidable circumstances, he will not be able to join us. However, he is with us in spirit. Mumekubali apology? Asante sana. I would also like to recognize one more person who we seem to have forgotten from the county of Garissa. Please.
Good morning. Mohammed Mobuzo is my name, County Commissioner Garissa. Thank you.
Asante sana. That's the County Commissioner from Garissa, one of the 5 counties who will be benefiting from this project. There's one more.
Okay, thank you. My name is Dr. Kennedy Rateng from Kenya Medical Training College.
Asante sana. Karibu sana. There's also Amplify Girls. Amplify Girls, the representative.
morning, everyone. My name is Lucy Minayo, co-CEO at Amplify Girls.
Asante sana, karibuni. And now we would like to get context about what we are doing here today. We would like to better understand the vision and expected impact of this initiative. And we will now have the presentation of the Her Health Project, Her Health Initiative by Fidelis Ndungu, the Deputy Director, NCPD. Tumpigie makofi as she makes her way to the podium.
Good morning. Good morning. We want to get the context. We want to know why the 5 counties, why not 7, why not 8, but the specific five counties that we are dealing with this morning in this initiative. I'm waiting for the presentation to be on. It's with the team, RH&K team. Okay, just hold on a little. This is the first presentation, and we want to know why those very 5 counties. And as we wait, we've had the reflection. Nelly has really painted a very faint picture of that girl. And you'll notice from the name of the initiative, it is Her Health Initiative. So from the 5 counties, we want that girl to own this initiative, and we want to support her so that she can see her life go to completeness, not cutting off her life because of a teenage pregnancy. And where those counties do female genital mutilation, we don't want her to have all those vices, but we want her to have a fulfilled life just like that other girl. Let me just give an example. For example, in Nairobi. All right, thank you. That is the presentation that we are going to make. And I'm going to start with some national statistics. And by 2030, the population of this country will be over 50 million. Actually, to be precise, will be about 60 million. But by mid-2025, that is last year mid, we were about 53.3 million. When it comes to fertility and family planning, we have adolescent fertility, which has disparities, very notable disparities, and you'll see them in another slide that will be there in those 5 counties. And then also we have the issues of modern contraceptive use in the country, and also you'll find in the 5 counties what is happening there. When it comes to maternal mortality, this initiative will also be looking at the maternal mortality, and one of those counties has the highest maternal mortality in Kenya, and maybe that is even why this initiative is there. Adolescent girls and young women, again, in the rural areas, information, has it reached on HIV/AIDS? Since 1999, when we started the fight against HIV/AIDS, has the information reached in the rural areas? And that is also something that we'll be noting in these 5 counties. Next. Now, that is the data. Those are the indicators that we have. We have national data where the maternal mortality ratio in the country is 355 deaths per 100,000 live births. And I want to take a picture because we are always blamed of having data that somebody may not understand. But let us assume we have 100,000 women who have had a live birth. Out of those 100,000 women, 355 of them die while giving life. And if we go down on the same statistics, we go to Garissa County, We see out of 100,000 live births that happen in Garissa County, 641 women die due to a maternal mortality or a complication. And this number, it will combine with systems, it will be combined with information, and that is why we want this particular girl, this particular woman, not to die while giving life. We go to teenage pregnancy. The national rate is 15%. That means out of 100 teenage girls, 15 of them don't complete school. They have to drop out of school because of a teenage pregnancy. And we'll just go to Samburu County, which is one of the focus counties. And we are going to assume we have 100 young girls in a class or in grade, let me say grade 6. And 50 of those girls will need to drop out of school because of a teenage pregnancy. And this particular initiative wants to ensure that the 50% of girls in Samburu, all of them, they finish their school. We go to unmet need for family planning, and the national rate is 14%. But you'll find that the red marks the 29% again in Samburu. We'll find the 30% in Pokot. But again, as we are talking about systems, the common mwananchi does not procure the commodities. It is the government that procures the commodities to health facilities. That is why, again, we bring on board the work of systems, procurement for family planning commodities, so that they lead to the health facilities, so that this young woman, when she goes to the health facility, she finds that the family planning services are being offered there, including the commodities. We go to modern contraceptive use. That is the modern use of family planning. And again, we'll find in Garissa, we have less than 1% of women who use a modern contraceptive method. And we know the efficacy of modern contraceptive methods is higher than the traditional ones. And again, we need also to look at this. And also in Tana River, you'll find it's just 1% of women there that use a modern method of family planning. HIV knowledge and prevention. This one, the fight started back in 1999, and it is sad to see the data there that at national level, only 59% of people, of the young women and girls, have information on HIV prevention. So that means that the rest, that is 41%. Are the only ones that have the information. But 59% of them, they do not have a way of how they can prevent themselves from HIV/AIDS. And then we'll find Garissa, 15% they don't have. And also the 15% have. They are the only ones who have. So we are having a cool, it's what percent? 100 minus 15 is 80? 85%. They do not have any information on how they can prevent themselves from HIV/AIDS. Next. Now, let us look at the system barriers in sexual, reproductive, and maternal health. Access, now we are looking at access. And when it comes to financing, like I said, the government needs to take lead in this when it comes to financing. And the health financing, we are 2% of GDP, and that is below the UHC benchmarks. And also, we do not have a dedicated sexual, reproductive, and maternal health budget line that we need to put on board. And then we have a lot of heavy dependency. And if we see on what happened to Trump and USAID, then the government needs to come on board and take this initiative as a first priority. Then we come to data and accountability. We have weak adolescent data, especially when it comes to those that are 10 to 14. We realize even the Kenya Demographic and Health Survey, we start collecting data from 15. So we have that data that is not available for 10 to 14, but again, we can always get it from service data from the Ministry of Health. Then we have 31% of facilities with electronic systems. But we need our facilities. Actually, when you get into a hospital, your data is recorded and retained, meaning that even when you go for a repeat visit, that particular data can be accessed from the system. Then we have limited youth or community voice in decision making. Are we still putting our adolescent and our young people on the table when we are making decisions? On service delivery, we have workforce shortages and also maldistribution. Then we have limited youth-friendly services. This is something that we have been talking about. And then we also have only 40% of facilities that provide maternity services. So meaning the 60%, they do not provide maternity services. And that is where we want our young women, our young girls to go and deliver. And then we expect them actually to have life after delivery. So we need also to ensure that these actually services are available in our health facilities. We have limited skilled birth attendants and also antenatal coverage. We want our young women, once they get pregnant, they get the antenatal services by a skilled birth attendant, and also even when giving birth, they are attended by a skilled birth attendant. Lastly, we have the socio-cultural environment, and we still have the female genital mutilation. We also have issues of child marriages, which are forced on girls. And then we also have stigma around adolescent sexuality, and also we have limited age-appropriate sexuality education. Still that one that we know schools actually provide, but I think it is still limited. And we need, when our young girls leave school, we need them to be equipped with information, and then we also provide the services and where they need to actually go and get those services. Next. So our approach in this particular initiative, we want systems that work for this adolescent girl, for this young woman. So in governance, and that is why our county commissioners are on board, because in those very 5 counties, we shall kind of have a technical working committee that actually will be looking at data, and so at least we can also track progress. Where are we at by the time we start? Where we'll be at by the time we actually complete this initiative. So we have a NCPD that is led by national and also county coordination, and that is where we are having on board our regional population coordinators from the 5 focus counties, actually, who will actually also be leading in this particular process. And then we will also have policy alignment and accountability at governance level. And at financing, we'll advocate for national and county sexual, reproductive, and maternal health budgetary allocations, so that at least they can support the activities that will be put on board. On service quality, we'll have adherence to Kenya Quality Model for Health. And then we ensure there is availability, accessibility, and affordability for all the commodities that we'll be using. And we, not only the availability and accessibility, but we also want them to have quality. Then we have provider training and youth-friendly services for young girls and women, so that they are able to get the information that is required to help them in their sexual reproductive health. And then we need to have strengthened referral and commodity systems. We don't want when a young girl goes for a young woman goes for a commodity or a service at a health facility, we don't want to tell her to go home and come after 2 weeks. But if that particular facility is not having that particular health facility is not having that particular service, we want her to be referred to another facility that will help her. On data, we need to improve the use of sexual, reproductive, and maternal health data, and this one will be utilized for planning and monitoring on progress. And then community and agency, where we need to have strengthened social accountability mechanisms. And this is where we'll have health facility management committees that will be put on board, and they'll also be help us actually when it comes to accountability. Then community engagement and norms change. We have the community health promoters. We have the religious leaders to be on board. And then also we have to strengthen adolescent voice. We ensure those adolescents, those young women are on the table when discussing. We don't want to discuss issues and matters adolescent when they are out, but we want them to be on the table. And that is it. Thank you very much.
Thank you very much, Fidelis Ndungu from NCPD. I think if I did such a good presentation, I would be very disappointed with how you people have clapped for me. So we can do better, right? Asante sana, Fidelis. Now, I would like to invite the choir to the stage so that they can entertain us briefly. But even as they come on stage, there are women in this room. There are men in this room. So we have all experienced pregnancy in one way or the other. You may not have been pregnant, but you know someone who has been pregnant, right? The older women who are here, hi. Hi. You know what pregnancy and childbirth looks like, right? The stress that comes with the morning sickness, the stress that comes with going to see your gynae, the stress that comes to that moment when you have to give birth. Now imagine an adolescent girl going through that alone. She has no one to turn to. Can you see her? Can you see her? That is who this project is for. This initiative is for. Karibu sana kwaya. That is NCPD choir.
Uongozi maana yake uongozi wa uwezo uliopewa na watu kuwahudumia mahitaji yao na kushughulikia maslahi yao. Uongozi watoka wapi? Uongozi watoka kwake Baba Mwenyezi Mungu, wateule wake aliyewateua kuwaongoza watu kwa mapenzi yake, tupate uhuru katika nchi ya Kenya. Tumebarikiwa sana kupata viongozi wa busara sana, kutoa shukrani kwa Mwenyezi Mungu. Nasi wananchi Kenya sote tunalo jukumu la kulinda nchi yetu na kumsaidia kiongozi wetu katika kazi yake ya kujenga nchi. Nasi wananchi Kenya sote tunalo jukumu la kulinda nchi yetu na kumsaidia kiongozi wetu katika kazi yake ya kujenga nchi. Kenya ni imara, Kenya ni imara, sote tunajivunia. Kenya ni imara, sote tunajivunia. Kenya ni imara, sote tunajivunia. Kenya ni nchi nzuri sana, lazima tuilinde. Kenya ni imara, sote
Asante sana, NCPD Choir. Thank you so much for that wonderful, wonderful entertainment. Tuwapigie makofi tena. Asanteni sana. So we'd like to give an opportunity to representatives from the 5 counties where this initiative will be taking place, so that they can tell us what this initiative means for each of these counties. And I would like to start with Aden Ibrahim, the County Director Health from Garissa County. Karibu sana. Tumpige makofi as he makes his way to the podium.
And good morning, and thank you very much, and with all the protocol observed, and thank you very much for this health project or initiative launch. I think this is one of the great initiatives that really address the key issues that has been highlighted by many of the speakers, and including the DG for National Population Council, the DG for Health, among other speakers highlighted for these 5 selected counties. I think Kenya has made a lot of impact in terms of achieving milestones for maternal and child health, but that notwithstanding, still a lot of disparity and gap exists within the country and within the counties. And this is associated with issues to do with access and equity. Access in terms of accessing essential services for these girls when they need it in terms of timely manners, and access in terms of commodity availability, distance to healthcare facility, healthcare financing landscape, among other challenges that do exist. And some of these counties are in the arid areas where there's a lot of distances for accessing these services still exist. Because the DG for NCB mentioned about Ijara in his remark, but I can tell you, if you look at sub-county in Garissa called Fafi, it is 15,900 square kilometers. But if you look the whole of central Kenya and Nairobi included, that distance is not there. And the distance in that sub-county for one health facility to the other is around 60 kilometers. So that shows you the disparity that exists even within the county itself. So, and I think this is a good project in terms of ensuring that we have issue of equity, issue of policy and healthcare financing is amplified and is able to address some of the key challenges that exist within these counties. And ours is to say thank you for the initiators of this project, and as a county, we are ready to work and support and work with you so that we have to have the impact that it deserves to achieve, so that we are able to reverse some of these trends or statistics that has been highlighted in the presentation. Thank you very much, and God bless you all.
Thank you very much. That is the County Director for Health from Garissa County. I am also reliably informed that we have in our midst county commissioners from these 5 counties. I believe we have the county commissioner from Garissa. Please. Karibu sana. Karibu. Please come to the stage. Karibu.
Good morning, ladies and gentlemen. Allow me to ride on the already established protocols. My name is Mohammed Mwambudzo, as I had earlier announced. Garissa is as vast as the director has put it, and the challenges are many. But I'm very hopeful that this initiative, not a project, and I really love the idea of it being an initiative. Because if it's a project, then it will come and go. But if it's an initiative, then we are expecting it to stay as long as the need is there. I've been in Garissa for the last 2 years. Unfortunately, I'd served there before as a DO. And very little has changed. So the plight of the girls needs your help. A lot needs to be done, and we would welcome this new initiative, and we'll give it all the support that it deserves. Thank you.
Thank you so much, Mohammed, County Commissioner from Garissa. Asante sana. Do we have the County Commissioner from Samburu? County Commissioner Samburu? Homa Bay? West Pokot? Do we have the county directors for health? Yes. Please come to the stage. Tumpigie makofi so that he gives us a picture of what it looks like in West Pokot or Samburu? Oh, from West Pokot. Sawa sawa. Karibu.
Good morning, everyone. So I'm not the county director. I'm in for the county director, West Pokot County. My name is Nancy Chebet. And for West Pokot, I think the challenges are those challenges that are in arid and semi-arid challenges are the same challenges that we are experiencing back home in West Pokot on matters SRH. Some of the other contributing factors among what my peers had mentioned are factors to do with FGM and early marriages. For us, FGM is really a broad issue across the county and an aspect of early marriages despite the efforts that has been put in place, but over time nothing much has really changed. So this tends to increase the number of teenage pregnancies around and also challenges to do with access to service delivery. Also to mention on that, West Pokot is a vast area, and I think currently we only have 2 facilities across the counties that offer like cesarean services, and one is a mission hospital and the other one is a public facility. So you can imagine a population of around 1 million only accessing cesarean services, in one healthcare facilities. So we really have a challenge on matters access, also the diversity, and also the illiteracy level. Our education level is around 47%, that is access to education. So we're really not doing well. So her health project, I think it has come at the right time, in handy, to enable the county address some of these challenges. As a ministry, I think starting last year, we are doing some baby steps on matters MPDSR audits to be able to see how bad we are doing. And it is shocking because in a week you can have like 2 or 3 maternal deaths. And that really is, we need to have the data, yes, but that aspect shows the gaps at the county level. So her project, I think it has come at the right time when we have the data, and we have also means, and we'll have a platform to be able to discuss these issues without fear or favor. So I think for me and my team and of West Pokot County, we really appreciate the project and we really welcome it so much. Thank you, sir.
Asante sana. She's given us a very vivid picture of West Pokot County. I would like to call onto the stage Dr. Oscar Endekwa. He is the County Director for Health from Tana River County. Karibu. Tumpigie makofi.
Good morning. Thank you. All protocol observed. I'm called Dr. Oscar Ndekwa. I work for the government of Tana River. And Tana River borders Garissa. So whatever my colleagues said, we share a lot. But Tana River has two issues. We have what we call riverine. So we have River Tana. That is the river. But the place is called Tana River. So a lot of our population is along the river. But we have what we call hinterlands. So if you were to look at the facilities in Tana River, they're actually all along the river. But now we have that population. There's a place called Waldena. From Hola, our headquarters to Waldena is 132 kilometers. Okay? By the time you go hit Kitui, you have another about 62 kilometers. Now, surveillance of maternal services in those areas is very difficult because there are very few facilities. Now, what about the girl child? The education sector, again, you find the same almost placement. We know girls are safe when they are in school. Girls are safe when they're in school. But then some of those areas, it's only, you don't get a lot of boarding schools. Okay? So for as long as there's a problem in accessing health, accessing education, then we have a problem in terms of being able to even do surveillance. By the way, the data that I see there, if you tell me, probably me, I'll say it's not true, okay? But I know it's true because there's no surveillance there. Okay? So it takes, if right now Hola Hospital is cold, you go pick a mother in Waldena. The ambulance there has to come all the way, 132 kilometers. But what if it has to go to Kalalani, which is another 50 kilometers? Are you getting the picture? And that is just one stretch. If you are going to Garissa, my senior there knows, the moment you hit a place called Basargasa, you are in Tana River. And along all that stretch until you get to Garissa, there are only two facilities, Bangal and Madogo. Okay? So you can imagine now you are going to Boka. Boka borders that Park Kuleju. Yeah? Huh? Yeah? Yes. So the distances are actually serving bad. A lot of our facilities, rural facilities, have either one or two nurses. We know nursing is the backbone of the health system. So if that one nurse goes on leave, you close. Okay? So sometimes the problem we are having is how do we do surveillance to know exactly? We think we know where the problem is, but are we dealing with scientific data? So we are hoping that, and I'm happy, I had to travel overnight by bus to welcome this initiative to Tana River. So as you come, we'll be there to discuss with you so that we know what interventions can we enhance so that we can keep the girl safe. We also have the issue about, I have my SRH coordinator here. Where is she? Hawa? No, this girl has put a lot of men, she's there. A lot of men are in jail. A lot of men are in jail because of messing with girls. Okay? Those are some of the issues that we'll be talking. So we are there, the will is there, we are working hard, but the question will be looking at what are the gaps that we can address, what can we refine. Only two facilities right now are offering emergency obstetric care, Hola and Ngao. Bora is having a bit of problems. We are trying to work with Madogo. The question is, the girls are the ones who are likely to have problems during labor. Look at it, senor. So we want to look at that and make sure that progressively we make it safe for them. So I want to thank you for this opportunity. Thank you for choosing Tana River. Unfortunately, we didn't want to be in this project because of those indicators, but because of them, we are in. Thank you.
Asante sana. Dr. Oscar Endekwa, County Director Health from Tana River County. And I'm also informed that in our midst is the Samburu County Director for Health, Karibu sana. And as he makes his way to the stage, I think one thing we can agree on is all these counties have an issue with distances to health facilities. And for those who've traveled to those counties, you know what it looks like kwa ground mambo yako kama hivyo. Karibu.
Yes, good morning. I'm Augustine Lemugonapi, County Director of Health. I think this initiative came the right time for Samburu County. As you know, we are leading in teenage pregnancy. 50% of our girls are getting pregnant during the teenage age. Secondly, our county is too fast, about 21,000 square kilometers, with only 98 facilities, cutting across the same. But most of the things, our main problem is one, we're having a moving population. One time in a year, our population, most of our population are in Turkana. Sometimes again, it will be in Marsabit County, Isiolo. So we have that moving population. So for you to be able to follow them, you need to have a good initiative. And this is one of them, for us to meet those. Thirdly, our education level is too low. About 80% of our populations are illiterate. So we still have those taboos, those cultural practices within Samburu community. So what we need most in Samburu County is advocacy on the right health seeking behavior in Samburu County. Otherwise, us in Samburu County, we welcome this initiative, and I'm assuring you 100% partnership from the Samburu County. Thanks.
Thank you. Thank you, Augustine, for letting us know what the reality on the ground is in Samburu County. I would like to recognize the presence of Ms. Mary Wandia, the Regional Director, Africa Co-Impact. Karibu sana. And at this juncture, I think it's time we take a break, have some tea, and then we will come back and there'll be a skit from Maono Group so that we can truly understand. Watu wanaweza kuongea, lakini saa zingine ni vizuri kuona. Si ndio? Sawa sawa. So we can have some tea. You leave through that door on your right. Karibuni.
It is an honor to welcome you to the 8th Pan-African Adolescent and Youth Sexual and Reproductive Health and Rights Scientific Conference. This annual event unites governments, civil society organizations, academia, and the private sector leaders with a shared commitment to improve and advance access to AY SRHR across Africa.
This conference is not just timely, it is urgent. It's our collective declaration that we will not allow regressive ideologies to hijack our health, our rights, and our futures. We are here to reclaim the narrative, to place facts before fear, science before stigma, and rights before repression.
Today's youth, they are the most informed, most connected, and vocal generation in history. They are demanding for change. They are claiming their space and calling for their rights, including the rights to comprehensive sexual and reproductive health education, services, and dignity.
Today we are reminded of the importance of SRHR, that it is a fundamental right. And if you want to see empowered young people, this is where you start.
I am super excited for the first ever Pan-African conference. I'm looking forward to learning more about what my ideas are and how they can be taken into consideration.
Coming from a marginalized community, I find this as a great opportunity for me to learn more about reproductive health.
Really looking forward to learning. I want to learn about the policies. I want to learn about the new innovative solutions that youths are coming up with. I also want to give power to my voice. I want to be part of the conversation.
This year I'll be presenting an abstract on how to use the law to end teenage pregnancy. See you at the conference.
Ukishaangalia expiry date, kipata expire unatoa pack moja kama hizo. Ni tatu nimetoa moja.
Now we are at Mtito and we are here to talk to people and the community about reproductive health and why this movement is important for young people, why this movement is important at such a time when it comes to reproductive health.
Changamoto zinazokumba wasichana sana sana ni mimba za mapema, dropout of schools, depressions, ugonjwa wa zinaa.
Wengi wetu tunaacha shule sababu wazazi wetu hawana fees. Twashika mimba tukiwa na miaka 12 na tukishika mimba tukiwa na miaka 12, kama uko shule huwa tunaacha.
Tatizo kubwa hapa ni depression. Tunaomba kama wasichana na hata vijana sana tupate guidance and counseling.
Nimeenjoy sana kujifunza ni njia gani zitatumika katika kupanga uzazi, utumizi wa condom, athari za mimba za mapema, wazazi kuwajibika katika kutekeleza majukumu yao.
This is a very critical conversation that we need to go and give this feedback to the policy makers, change makers, or people who are able to help us.
I really want to appreciate RHNK for this kind of vision, especially at this time when you're having a lot of global shifts in the way work around the things we do is changing. It's important to also have those regional lens and perspective in the work that we are doing. And organizations like RHNK, I think they really thought it wise to have this kind of conference on that scale.
My expectation was to come and hear how are young people dealing with cuts in funding, anti-rights movements, misinformation, disinformation, and how are they partnering across the continent to address these particular issues. And so I've heard of different strategies, different tactics, build coalitions with different partners that will be able to help us address legal policy issues affecting young people. So I feel extremely satisfied with the last few days at the conference because they have truly met my expectation.
It looks like a world to me where progress isn't measured solely by individual achievement, but how well we rise together. It's about shared prosperity, resilience, and purpose. I'm talking about a future where inclusive innovation, shared visions and values, collaborative systems, resilient infrastructure, and collective mindsets are all a part of the future that's coming.
We are setting the agenda for Africa. We are setting the agenda on human sexuality. We are setting the agenda on adolescent sexual reproductive health and rights. The agenda which has been set here is consensus from governments, NGOs, civil society organizations, that is, and also private sector. People have agreed on priorities that we need to implement, where we need to put resources. I'm happy that that happened, and we have brought sectors together. They are going to be working together more, and we will achieve more.
This year's conference surpassed my expectations in a number of ways. The quality of conversations that were going on was quite high. There was diversity in those conversations, but importantly, I saw a lot more young people participating in panels, different conversations. There were specific spaces set aside for them, and that is commendable.
Hello, my name is Lucy Wanjiro. I am a youth advocate at RHNK. I'm here at the 8th Pan-African Conference, Youth Cafe Writing Wall, and I'm expressing my thoughts and my opinions on SRHR.
As a youth, I was privileged today to present an abstract focusing on how we use digital platforms to advocate for gender-based violence.
We came in with a few abstracts, of course, to share and amplify some of the work that is being done at the community level, but also within the policy sphere. Some of the advocacy work we are doing and interventions we are doing. So, of course, this has been a good platform to just showcase that, but also to amplify some of the voices that were not able to be here.
In terms of the policies, we have enough policies. I think what I would like to see improve is the implementation and the alignment in terms of the disparities that exist within the legal frameworks around sexual reproductive health and rights.
I like that the outcomes of this conference and the interaction, the intergenerational communication and just mentorship that has been going on, we have been able to engage with the funders, we've been engaging with the policy makers, we've engaged with government, and we have expressed the need for these needs to be met. We have expressed how they should be met, and we've expressed how we're taking part in addressing them. And I feel like the results and the things that will come out of this conference are going to be amazing and mind-blowing.
Let this conference be a space where new partnerships are born, where actionable commitments are made, and where the future of adolescents and youth sexual and reproductive health in Africa is reimagined.
Let us rise to the moment together. Let us build a future where every adolescent and every young person can live with dignity, make informed choices, and claim the right to a life of possibility and empowerment. It is an honor to welcome you to the 8th Pan-African Adolescent and Youth Sexual and Reproductive Health and Rights Scientific Conference. This annual event unites governments, civil society organizations, academia, and the private sector leaders with a shared commitment to improve and advance access to AY Aserachar across Africa.
This conference is not just timely, it is urgent. It's our collective declaration that we will not allow regressive ideologies to hijack our health, our rights, and our futures. We are here to reclaim the narrative, to place facts before fear, science before stigma, and rights before repression.
Today's youth, they are the most informed, most connected, and vocal generation in history. They are demanding for change. They are claiming their space and calling for their rights, including the right to comprehensive sexual and reproductive health education, services, and dignity.
Today we are reminded of the importance of SRHR, that it is a fundamental right. And if you want to see empowered young people, this is where you start.
I am super excited for the first ever Pan-African conference. I'm looking forward to learning more about what my ideas are and how they can be taken into consideration.
Coming from a marginalized community, I find this as a great opportunity for me to learn more about reproductive health.
Really looking forward to learning. I want to learn about the policies. I want to learn about the new innovative solutions that youths are coming up with. I also want to give power to my voice. I want to be part of the conversation.
This year I'll be presenting an abstract on how to use the law to end teenage pregnancy. See you at the conference.
Ukishaangalia expiry date kipata expire unatoa pack moja kama hizo. Ni tatu nimetoa moja.
Now we are at Mtito and we are here to talk to people and the community about reproductive health and why this movement is important for young people, why this movement is important at such a time when it comes to reproductive health.
Changamoto zinazokumba wasichana sana sana ni mimba za mapema, drop out of schools, depressions, ugonjwa wa zinaa.
Wengi wetu tunaacha shule sababu wazazi wetu hawana fees. Twashika mimba tukiwa na miaka 12 na tukishika mimba tukiwa na miaka 12 kama uko shule huwa tunaacha.
Tatizo kubwa hapa ni depression. Tunaomba kama wasichana na hata vijana sana sana tupate guidance counseling.
Nimeenjoy sana kujifunza ni njia gani zitatumika katika kupanga uzazi, utumizi wa kondom, athari za mimba za mapema, wazazi kuwajibika katika kutekeleza majukumu yao.
This is a very critical conversation that we need to go and give this feedback to the policy makers, change makers, or people who are able to help us.
I really want to appreciate RHNK for this kind of vision, especially at this time when you're having a lot of global shifts in the way work around the things we do is changing. It's important to also have those regional lens and perspective in the work that we are doing. And organizations like RHNK, I think they really thought it wise to have this kind of conference on that scale.
My expectation was to come and hear how are young people dealing with cuts in funding and to help us address legal policy issues affecting young people. So I feel extremely satisfied with the last few days at the conference because they have truly met my expectation.
It looks like a world to me where progress isn't measured solely by individual achievement, but how well we rise together. It's about shared prosperity, resilience, and purpose. I'm talking about a future where inclusive innovation, shared visions and values, collaborative systems, resilient infrastructure, and collective mindsets are all a part of the future that's coming.
We are setting the agenda for Africa. We are setting the agenda on human sexuality. We are setting the agenda on adolescent sexual reproductive health and rights. The agenda which has been set here is consensus from governments, NGOs, civil society organizations, that is, and also private sector. People have agreed on priorities that we need to implement, where we need to put resources. I'm happy that that happened, and we have brought sectors together. They are going to be working together more, and we will achieve more.
This year's conference surpassed my expectations in a number of ways. The quality of conversations that were going on was quite high. There was diversity in those conversations, but importantly, I saw a lot more young people participating in panels, different conversations. There were specific spaces set aside for them, and that is commendable.
Hello, my name is Lucy Wanjiro. I am a youth advocate at RHNK. I'm here at the 8th Pan-African Conference, Youth Cafe Writing Wall, and I'm expressing my thoughts and my opinions on SRHR.
As a youth, I was privileged today to present an abstract focusing on how we use digital platforms to advocate for gender-based violence.
We came in with a few abstracts, of course, to share and amplify some of the work that is being done at the community level, but also within the policy sphere. Some of the advocacy work we are doing and interventions we are doing. So, of course, this has been a good platform to just showcase that, but also to amplify some of the voices that were not able to be here.
In terms of the policies, we have enough policies. I think what I would like to see improve is the implementation and the alignment in terms of the disparities that exist within the legal frameworks around sexual reproductive health and rights.
I like that the outcomes of this conference and the interaction, the intergenerational communication and just mentorship that has been going on, we have been able to engage with the funders, we've been engaging with the policymakers, we've engaged with government, and we have expressed the need for these needs to be met. We have expressed how they should be met, and we've expressed how we're taking part in addressing them. And I feel like the results and the things that will come out of this conference are going to be amazing and mind-blowing.
Let this conference be a space where new partnerships are born, where actionable commitments are made, and where the future of adolescents and youth sexual and reproductive health in Africa is reimagined.
Let us rise to the moment together. Let us build a future where every adolescent and every young person can live with dignity, make informed choices, and claim the right to a life of possibility and empowerment.
tober, Nyasaye ni tober. Oh, Nyasaye ni tober, ni tober. Nyasaye ni tober, Nyasaye ni tober. Duwe ya miela miela, miela miela. Duwe ya miela miela, duwe ya me. Oh, duwe ya yonga yonga. Seve, rekani seve seve, rekani seve seve, rekani seve, oh rekani seve seve, rekani seve seve, rekani seve seve, rekani seve seve. Hey Mungu yu mwema, yu mwema. Cheza cheze, cheza cheze, niacheni cheza cheze, niacheni cheza cheze, niacheni cheza cheze, niacheni cheza cheze. Ngai ne mwega. Sunga sunge, ekai sunga sunge, ekai sunga sunge, ekai sunga sunge, oh ekai sunga sunge, ekai sunga sunge, ekai sunga sunge, ekai sunga sunge. Sawa. Sawa.
Malaika, nakupenda malaika.
Oh, malaika, nakupenda malaika, 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 nakupenda malaika. Nami nifanyeje kijana mwenzio, na mali sina weninge kuoa malaika, na mali sina weninge kuoa malaika. Sina wengine kuoa mali sina weninge kuoa malaika. Kidegen, oh kidegen, oh kidegen, malaika. Kijana mwenzio, na mali sina weninge kuoa malaika. Na mali sina weninge kuoa malaika. Ninge kuoa malaika, ninge malaika mali sina, malaika mali sina, kidosho mali sina, mrembo mali sina, kipusa mali sina, opera mali sina, mhana mali sina, kipusa mali sina, malaika mali sina, malaika mali sina, ningekuoa malaika. Silaha ya kweli. Wakati ni sasa, usiogope, changamoto ni shule, kujituma ndiyo silaha ya kweli. Hey. watu amen, wakati ni sasa.
Tom Haoya and NCPD Choir. Tumpigie makofi, tuwapigie makofi. Msipige makofi ni kama mko na wivu. Kama hamna sauti kama hizo, wapigieni tu makofi. Asanteni sana NCPD Choir led by Tom Haoya. And we would like to continue with the program, but I would like to briefly give an opportunity to representatives from different counties. We have the County Commissioner from West Pokot, Mr. David Saruni, Joseph Mwangi, County Commissioner, Tana River, and Odhawa Jacob, County Reproductive Health Coordinator from Homa Bay. Ni wao hawakupata nafasi ya kuzungumza. Let's start with Odhawa Jacob from Homa Bay County, the County Reproductive Health Coordinator. Karibu to the podium so that he can share with us the reality on the ground and why this initiative is important for girls and young women, adolescent girls and young women in Homa Bay County. Karibu.
Good morning, everyone. Good morning once again. Allow me right on the protocols that had been observed here before. I'm called Odhawa Jacob, Reproductive Health Coordinator, Homa Bay County. Today, we are here for the launch of Her Health. Yes, it is written a project, but if you are keen on the CEO RHN speech, Nelly, then we will substitute the word project with initiative. Across all these counties, they have different diversities and different challenges in their areas. And therefore, as this project comes in, or this initiative, each region will have specific interventions based on their local challenges. If you're all aware of Homa Bay is a county along the lake, and therefore, obviously, we have a moving community that's always along that community or that region. And as we talk about the young girl, there's both adolescents and the youths, but there is a very key component. I don't know if it is probably being observed in Homa Bay alone, but I've indicated that each region has its own specific challenges. As we discuss this, I've never heard, even during the speeches, anybody mentioning the young boys. The young boys. Because you cannot sit and pretend that the contributors to the teenage pregnancy is not the young boy. Probably around 90%. You engage these young girls, you have fruitful deliberations with them, but at the end of the session, when they walk away, they join the very, very boy. And I don't know how possible is it for an empowered girl to stay or marry an empowered boy. Is it possible? It's not, probably 1%. But an empowered boy is able to cooperate and stay with an empowered girl. And therefore, we have to think about this as we start to implement this initiative. That's when we will address some of these challenges we are facing. And it is in the public domain. We have maternal mortalities, the perinatals. A good population are young girls. Yes, I know as a country, already there have been a talk. They have developed even a curriculum about preconception care. But even from this setting, I know there are those who have given birth or participated. How many? I don't want you to raise your hand and respond. Among your kids, did you plan, I want this pregnancy this month? Even we seated here, a number, they just realize themselves pregnant. And therefore you can see and look, find where the young and empowered about herself, her body development. This calls for stakeholder. Departments, individuals coming together and having a talk, and must be a very much open talk and candid, so that we come up with a very clear interventions, and also involving, but to some extent, the data we have, I'm sure, recorded and reported. We make the milestone to be able to address the R. And this R cannot be, there's no HR. The commodities, yes, we are fencing. During fence, what you have not allocated, and even the previous allocation, what did you appropriate towards commodity? And therefore, it is something that as a country and as a county, we must have a focus and prioritize for us to move. We were just blindfolded, but it is good in the whole country. We are now aware, and every responsible officers are aware that the donor world is dwindling. And it had been clear that by 2030, the country should be able to finance family planning on their own. If you ask the national government, what budget did they allocate last financial year that is now ending, and what percentage of that was appropriated? Same to the county. Same to the county. And if we are not able to say probably what were the challenges why we were not able to appropriate and think and start talking about ring-fencing, then we are missing the direction. We need to get those issues that made us not to appropriate even a single percentage, and probably now accounting on what the donor gave us to have made us to make the strides that the country has done. And therefore, as we walk, we are still requesting for the leadership. We know I think there's a committee national that will be updating the presidency, and also there's a dashboard by the county governance leadership, and therefore let that as figures. Let it be a dashboard to help us use those data to make decisions that are able to address that. And therefore, up to that point, I would say that this time, it is a time when both the national and the county government are in departments or officers who are allocating, and county assembly and the parliament. Without those two, even and RHN together, and CPD and health project at the Ministry headquarters, we welcome you to Homa Bay, and we will work together to ensure that we achieve together, not achieve as one-sided team, but as a community. And therefore, as we move, we will give this feedback to the leadership of Homa Bay, and we will ensure that this project becomes a future that would be talked about by the generations to come. Otherwise, thank you.
Asante sana. That's Odawa Jacob from Homa Bay County. I would like to call on stage Mr. Joseph Mwangi, County Commissioner, Tana River. Karibu sana. And after he's done with his remarks, we'll move straight to David Saruni, County Commissioner, West Pokot. Karibu.
Good morning, everyone. Good morning. Riding on the protocol already established, as you have heard, I'm Joseph Mwangi, County Commissioner, Tana River. I wish to thank the might behind this initiative. Actually, it will be of great help to us. The doctor who was here from Tana River actually explained the terrains of Tana River. Only that I will add that we have two types of economic activity, and that is agriculture and pastoralist. So most challenge is on the side of pastoralist, because like today, you can leave 1,000 people here. You come there after 1 month, you find empty structures, people have been moved. However, we have a problem in Tana River. When I was checking on the data there, the number of girls who are aware that condoms can prevent diseases, HIV. You know, hii Gen Z tuko nao, kitu anaogopa sana ni mimba. So they don't even understand that condom can prevent HIV. So we need to sensitize them. And I want to give a story where Masherima here, she has been leading the news while I'm talking in Tana River when there was a conflict between the communities. You know, since June last year, there has been like 14 deaths, and they resulted from a rape of a girl. We have inter-community conflict. One tribe, 2 men raped a girl from the other tribe. And then wazee walikaa committee, they agreed that the payment is 60,000. That, because she was raped by 2 men, each man will pay 30,000. And when they sit down, that money is not even going to the girl, not even to the mother. It is wazee to eat. Then there was a conflict in between because the money was not given in full. That is 60,000. And that triggered a conflict that resulted to 14 deaths. If we were able to talk to these girls, because when I was when I called them for an interview in my office, the girl said she didn't know that when she is raped, she is supposed to go to the hospital the way she is. So she just washed, she took shower, washed the clothes, and then there she is complaining. So we could not get evidence. So when you come on the ground through this health initiative, we'll be able to talk to them and tell them this is what you are supposed to do after something has happened. On the health centers, the doctor said here, I'm the chair of a fund called Equalization Fund. Last time we allocated funds because the fund go for the roads, electricity, health, and water. So this time around, when we get this allocation, which you are about to get now, we will put more emphasis on constructing and equipping health centers so that we are able to provide health to the people as much as possible. When we are doing, I will just finish. When we are doing a mobilization, 100% transition, after His Excellency President pronounced himself that we need to mobilize children to go to school. In Tana River, it was 21%. Mostly, girls had not even joined the school. You find a whole sub-county, we had only two students only transiting from grade 9 to 10. And it is because of the challenges. I talked to my women rep last week. I told her, I have inquired from the teachers, and they are telling me these girls, they are shying off because they don't have sanitary towels. And I told Mama County, you have to come, me and you, we go and distribute this. She's talking of distance. I told her, no, that one I cannot agree because there are buses for schools. We can ask the teachers to send the buses to collect the sanitary towels. No, she told me, even we don't have enough. I told her, no, I can talk to the PS. And I talked to the PS, Jeddah, Madam Anne Wangombe. She is a good friend of mine. And she has promised to provide more sanitary towels. So when this team come to the ground, they are wrote internally we are going to do for our girls. Thank you and God bless you.
Thank you so much. Let's have on stage David Saruni, County Commissioner, West Pokot, and immediately after him, we will get into our panel discussion. Karibu sana, David.
Good morning, everyone. Also allow me to write on the protocol already established. As you've been told, my name is David Saruni, County Commissioner, West Pokot. And mine is only a comment, very briefly. West Pokot is a county relatively small compared to the other counties, about 9170 square kilometers, with a very harsh terrain of mountains, the poor road accessibility, especially on the mountains. And you also have people living on top of those mountains in the lower belt of Turkwell, and also has some challenges because we are also bordering Turkana, Trans Nzoia, Elgeyo Marakwet, and Uganda on the western side. Probably this project has really come at the right time. Maybe this project, an initiative, will be able to address the challenges that sexual reproductive services that we are facing in West Pokot, especially because most of the problems that we are facing there are cultural in the dimension of early child marriages, which are very prevalent, and also the FGM, because those are also cultural. And I'm sure what has been, the project is also coming to address such issues. And more importantly, the project is also coming to, is using a multi-sectoral approach to be able to address these issues. And as it has been said, the problems are systemic, and therefore ours, I think, as heads of the counties, what we are going to do is to ensure that we coordinate the programs and the programs that are these programs to ensure that everybody is brought on board so that we can be able to address these issues. Otherwise, thank you very much.
Asante sana, David Saruni. He is the County Commissioner from West Pokot. Ladies and gentlemen, improving outcomes for adolescent girls and young women requires collaboration, strong leadership, and sustained commitment. And to better understand this, we now transition into our panel discussion where we will explore these themes deeply. And I would like to call onto the stage our panelists, starting with Ms. Mary Wandia, who's the Regional Director, Africa, Co-Impact. We will also have on our panel Dr. Johnston Kuya. He's the Senior Policy Officer, Strategic Partnership and Gender, Embassy of the Kingdom of Netherlands. Karibu sana. We also have Charity Koronya, representing UNFPA. Karibu sana. And Honorable Justice Jane Onyango. Honorable Lady Justice Jane Onyango. She's the Environment and Land Court Judge. She's also a member of the International Association of Women Judges, Kenya chapter. She's representing the president of the association. Karibu sana. Last but not the least, we have Julius Mbeya. He's the co-CEO of Loala Community Alliance. Karibu sana. Karibu. Everybody has a mic? There's one more here. Oh, you have one. Okay. Karibu. Okay, so we want to understand these themes more deeply, and I will start with a question that I hope all of us can respond to before we get into the specifics. Why is this moment critical for investing in systems that support adolescent girls and young women in Kenya? Let's start with you, Julius.
Yeah, good morning, and it's an important question. I think the statistics that have been shared are telling enough. And much as there is a focus on these 5 counties, I think there is an acknowledgement that this is a countrywide problem, that changes in these particular counties have the potential to change something across Kenya. And it's also testament to the fact that the problem is not equally shared across the country. The fact that there is a disproportionate impact that is faced by young girls and women, adolescents and young women across the country is not the same. And the realities in these counties, the reality in these counties are different, and so targeting counties with the most and the biggest problem has the potential to change the course of the country as a whole. So not just by addressing things at that level, but really looking at systemic issues that have the potential to change things across the country.
Thank you so much. Thank you for the question. I think this moment is critical, especially given what we know that has been happening to funding for health. And I think that it has taught us that we have to sort ourselves out. And so it means that at this moment, we really need to ensure that we have sustainable financing that is mobilized domestically, and that we also own the interventions that need to impact our people. Of course, philanthropy and other people can catalyze innovation, and development partners can support, but long-term impact depends on that domestic ownership. And so I think that's why, for me, this moment is very critical. Thank you.
Yeah, just to add to what my colleagues have said, first, I wish to really thank RHNK for focusing on this vulnerable group. So to me, this is really a timely intervention because the target group in itself is very vulnerable. They have been left behind, and there are so many challenges which really deny them access to services. Among them is the systems, of which the systems include the legal legislation and also the commodity itself. So to me, it's really timely, and because the group is very, very important, they are the future of the country, their needs are always sidelined.
Thank you very much. I think for me, looking at the presentations that have been done in the morning, just picture a young girl in Samburu, 16-year-old girl. And of course, we are used to our programs and projects, then development comes, and then of course services improve, we have outreaches, commodities are stocked, there is some bit of funding, and then the project ends, and then slowly all that we've done starts to slow down again. So from her perspective then, that support is just temporary. And I think that's the reason why we are here today, because our health project, I think our initiative, Nelly already told us, I think has something differently. And I'm very much impressed with the level of government participation from different quarters. I think that's quite crucial for this kind of work. So for me, I would say, in addition to what my colleagues have said, with this donor funding that is tightening up, services have to continue, and the systems needs to continue as well. So we just have to build a strong system, because they don't happen by accident. We have to do it deliberately, and I think that is the reason why we are here today. Thank you.
Thank you. Honorable Lady Justice, why is this moment critical for you?
For me, we don't use mics in court. Very juakali. Okay. First of all, I'm sorry that I am coming in this late. I had a list of cases to deal with, and I had to rush through it before coming. So I missed out on the presentation, so I'm a bit disadvantaged. But this is a topic that is very close to my heart. Those of you who know me in the room know that for the longest time I worked at FIDA for 11 years in my past life before I became a judge. So it's an area that is really, really close to my heart. And why it's important for us to focus on adolescents is because in most situations they are vulnerable, they are not able to speak for themselves. And you know that if we don't focus on this demographic, then we can end up losing a whole generation. So it's really critical that we ensure that they have access to this area of rights that is very specific, and that really where girls usually are the ones that suffer the worst form of effects when their rights to sexual and reproductive rights are violated. So I also looked at the areas that the project intends to focus on. I think it's spot on. You know very well that girls in those particular counties, which are generally underrepresented in most projects in the country, they are poor, they are not well educated. They don't have the services that they ought to have that we would readily have perhaps in other counties like Nairobi, Kisumu, and the big cities. So for me, I think it's really, really a timely project, one that ought to be supported. I'm aware of what's happening in the area of funding, even though I'm not in the NGO world anymore, but I've kept touch with organizations that are focusing particularly on the area that we are discussing and the shrinking of funding that's happening and what that really means for the girls and for the women of Kenya. So even though right now I'm busy dealing with Mogunda matters, my heart is still in this area. So I think I can be able to contribute to this discussion. Thank you.
Thank you so much. And because you've mentioned, you've spoken about global funding cuts, I would like to bring in the representative from UNFPA. In that context, how is UNFPA supporting governments to strengthen systems and ensure sustainability of sexual, reproductive, and maternal health interventions?
Okay, thank you very much. UNFPA works very closely with the Ministry of Health, NCPD, and partners including RHNK, Maria Stops Kenya, to really strengthen the systems. And one of the biggest things UNFPA has done, it is to support the government of Kenya to have a national integrated logistic management information system. This is the system which ensures that commodity are at the right place, the right quantity, and at the right time. Kenya has actually been able to win 3 global awards with a system that was developed by KEMSA staff and the Ministry of Health. This system ensures that at your desk, you can be able to look at your order which you have made, and you are able to see where your order is. It enables you to check also whether you are having commodities which are about to expire. So in short, we all know, the programmers in the room know that without commodities, there is no program. So the LMIS is very critical. And I've mentioned the partners because RHNK, Maria Stops are all members of what the Ministry of Health has established called the National Order Management Team. This is the team which oversees the commodity distribution and ensures that really the people get the right quantities. In addition, there are systems also in the county and at the sub-county level. There is the county order management team and sub-county order management team. Apart from the LMIS system, and just to say that this system was supported by UNFPA in collaboration with other partners, and it was purely for family planning. But I'm proud to say that with the Ministry of Health leadership, this system has been adopted by all the programs in Kenya. all the programs are now using the LMIS to ensure that commodity management is really working in Kenya. So I think it's good we really give a clap to the Ministry of Health and KEMSA getting 3 global awards as Kenya. I think it's a big plus. It's not that we don't know how to brag. I think it's the high time we start bragging for our achievements. Second is on the issue of commodity funding. UNFPA realized long time ago that the issue of domestic financing is a challenge, and I'm happy again to see the DG of NCPD here and Dr. Bashir. And with NCPD and the Minister of Health, Kenya signed a compact of commitment with them. UNFPA, signed a compact of commitment with the government of Kenya. And this compact of commitment ensures that UNFPA is able to contribute certain amount of value for the family planning commodities, and the government is able to also contribute. In this case, the compact was signed in 2022, and again, I'm happy to say that the government of Kenya has been able to honor the commitment. They have they have refunded UNFPA the value of the agreed commodity in 2022, 2023, and 2024. We are 100% sure that with Dr. Bashir in the room and Dr. Sheikh, that the government will be able to honor the other commitment. So with this compact, apart from UNFPA procuring and having the government contributing, it comes with a match fund, whereby for every dollar which the government puts in, UNFPA is able to give $1 on top of the normal routine commodities procured. For example, if the government is going to now procure commodities worth $200 million, UNFPA will be able to also procure the same dollar to dollar. However, there is a caveat that the procurement should be more all at the same level as the previous year. And that procurement should only come from the government of Kenya funding, not from partners. Just to add to that, the other thing again is that with NCPD, there has been a very high level advocacy also to ensure that the private insurance integrate family planning in their schemes. And NCPD has been leading this advocacy, and we have seen 3 insurance firms have been able to include family planning in their schemes. So an appeal to all of us as SRH champions, please ensure that your HR, when they are engaging the insurance at the beginning of the year, family planning is a package, not by the way, and it is really comprehensive and well spelled out.
Thank you so much. I would like to bring in Co-Impact, because you've been a leader in supporting locally led organizations to work closely with governments and other stakeholders to strengthen systems. What has informed this strategic shift, whereby do you see value in investing in systems rather than standalone projects?
Yeah, thank you for the question. So as our name, as we are named, Co-Impact, means we collaborate for impact as a philanthropic collaborative. And we actually did not begin as a strategic shift. We began with listening. So in your context. And the answers were remarkably clear. The leaders, they wanted to address root causes, not symptoms. They wanted to strengthen public systems, not building parallel ones, and strengthen these public systems with their communities. And they needed long-term flexible funding to do that, and the trust to be able to work with their governments. And that shaped our model. And so our focus is very simple. We identify organizations in the Global South that are willing to really transform public systems to impact millions of people. And we simply focus on strengthening health, education, and economic systems so that they can serve people more equitably and more effectively. But why systems and not standalone projects? It's because systems endure, they remain. Projects can deliver services for a few years, but strong systems continue delivering long after funding cycles close. And we all know governments do not operate on 2 or 3 year timelines, and so also sustainable progress should not be timed. So by investing in systems, we have seen local change makers leverage public resources, strengthen institutions, and scale impact far beyond what philanthropy alone could ever achieve. And our partnership with RHNK is a perfect example. They are not doing parallel service delivery. They are aligning with government priorities and designed for sustainability. And I think for transforming systems, working together is not a slogan.
Yeah.
It's a requirement. We have to work together.
Yeah. And for Luala, as a local organization working directly with government to strengthen health systems, I know in today you have a talk at Bugumbe Health Center on maternity services, contraception for men and women. What has been your experience on the ground? What approaches have worked well?
Yeah, thanks very much. I think the first place is to ask ourselves, how do young people access services? In my experience, I think we have an assumption that a young person will go to the health facility, talk to a nurse or a clinical officer who is either their uncle or somebody the age of their parents, and they would be able to discuss their personal matters and receive a service and go home. It just doesn't happen. And if there is experience that that happens, it is at the level of the percentages that we have seen. So I think we need to rethink how young people access services. And what we have experienced on our part is that young people receive services when they are reached by fellow young people. There are models that have been tested out here, youth peer provider models, where young people provide education to fellow young people, and then they refer them and direct them to places where they are receiving services. We know initiatives around youth peer provider corners or youth-friendly corners. We know initiatives that the ministry has driven around like whole site orientation, which is to work on the perceptions and attitudes of healthcare workers to be more receptive to the needs of young people. I think those are the things that we need to double down on so that we can actually ensure that young people are receiving these services, are in comfortable spaces, and healthcare workers are able to meet them and meet their needs. I think our experience in working with government is, number one, I liked what Nelly corrected here. When I saw this as a project, I said, project, great. How many projects has this government seen? Projects come and go. So if we are going to approach this as a project, then we'll give it a timeline, and then we'll do the activities and report on the activities, but we will still end up with the same results. So I think long-term view, knowing that in partnership with NCPD, this is not just about now. It's about leveraging resources beyond this partnership with Co-Impact, leveraging partnerships with other actors in this space so that we can look at long-term change in what is happening. Some of the counties that you have mentioned are counties where we are, and we are looking forward to collaborating with you all to ensure that we are doing this in a more collaborative way. The final point I wanted to make is you are on a good space, starting by co-designing and co-planning with government. And I like that NCPD is actually at the forefront of this, because that is when it really means that it's government-led. And so even at the county level, how do we ensure that our reproductive health coordinators, the directors of health, and the structures that we have at the county level are leading so that our role is more facilitative than leading? Thank you very much.
Thank you so much, Julius. I would like to bring in Dr. Kuya now. The Netherlands Embassy has taken bolder approaches towards long-term investments, particularly in system strengthening. Do you believe this level of transformation is achievable within the current developmental context?
Thank you very much. Yes, I do believe if we have to redefine our partnerships and our different models, I think that way, then we'll be able to achieve. If all of us as donors, as governments, as civil society, and private sector come together, move from this kind of a transactional relationship that we always have, what my brother is talking about, to co-investment in terms of shared outcomes, then I think it's possible we can be able to achieve this kind of results in a more institutional, but also, I would say, resilience manner. And I started by talking about the story of this girl in Samburu. But again, now if you flip it a bit, we have a county, I don't know, maybe from the 5 counties that were presented, there is one that they have a very strong, I think let me pick Homa Bay. It was very good to hear from the reproductive health coordinator. They have a very strong adolescent health annual plan. There is a protected budget line. There is a dashboard that tracks access to stockouts. Then we have a local private health technology firm that provides linkages between these dashboards to that national platform that was launched the other day. And then we have also a telehealth platform that connects rural providers to specialists at whatever place for advanced kind of consultation. And then there is a supply chain partner who ensures last mile delivery. And then finally, we have a civil society that continues to engage the county assembly on accountability, monitors implementation, the county reviews budget, and the story goes on. Then you're sure with this kind of investment, then services will continue even without funding. And that's exactly what we are trying to see if we can be able to reshape this architecture, but also ensure that services continue and are transformative at the end of the day. Yeah, thank you.
Honorable Lady Justice, what role does the judiciary play in protecting the SRMH SMRH rights for adolescent girls and young women in Kenya?
Okay, the role of the judiciary is to interpret the constitutional provisions on sexual and reproductive health rights, Article 26 to be precise. You know that it's usually very political, eh? So, yeah, our role is to interpret that section in a manner that ensures that the right is protected, as was the intention of Parliament. For that article to have been enacted in our Constitution, you're aware that there was a lot of discussion that went on. There was a lot of opposition to the right to sexual and reproductive health rights. Because everybody was just seeing a big banner written abortion, isn't it? They were not looking at all these other aspects of access to, information, access to commodities, and access to, access to abortion. Let's just call it by its name. So, when such cases come to court, then it is the duty of the court to look at that section, look at the case law from other jurisdictions, particularly the Commonwealth jurisdiction, because that's the one that we are able to draw our area of practice from, and to see what has happened in other jurisdictions with respect to this right. Is Kenya able to take bold steps to advance this right? And you know there have been a number of cases that have touched on this right. Just meant to mention just a few. The case that FIDA filed, Federation of Women Lawyers versus Attorney General. I don't know how many of you are familiar with that case, but the lawyers in the room can give you a brief, the brief facts and what the courts decided. We've also, the courts have also been able to look at the area of violence in the how do you call it? Obstetric violence. I know that back in the day when I was at FIDA, I really miss those days. I can see Lucy smiling. We did this report called Failure to Deliver. I don't know if you've all read that report. The experience of women interacting with the health system when they go to deliver, and the failure of that system, of the health system, to women, ranging from actual physical abuse, but also emotional, just the lack of support that the women are exposed to in the maternity wards. It was horrifying, to say the least. I don't know if copies of that report are still available at FIDA. I think I don't know if it was, Lucy, maybe you might be able to tell us. You've remained in touch more than I have, but it's a very telling report. A lot of research went into it. Visits were made to Pumwani and other hospitals just to document what women go through when they go to that maternity ward, and it was extremely horrifying. And I remember we presented that report to the Minister for Health at that time, and she promised that something would be done. I hope it has been done. I have not gone to the maternity ward since then. I went many years ago. But those who've interacted with the system would be able to tell us. Yes, so that's one area that the court is concerned with. We also, look at holding government accountable, because the government signs many laws, international laws touching on this area. So the role of the court, if one was to file a case, would be to see whether the government is actually honoring its obligation under the international statutes and obligations like CEDAW and others. And even under the ones, at the regional level, not just the international ones, but also the ones at the regional level. To what extent is the government able to be held accountable to ensuring that these rights are respected? And then, of course, the courts will sometimes issue what we call interdicts, where we feel this is an area that's provided for in the law. It looks aspirational, particularly when it comes to social and economic rights. The government will always say they don't have money to put into this, to realize this right. So the courts would come in to say, we are giving you a time frame. Come and report to us after maybe 6 months. At least show us that you're taking steps to ensure that this right is actualized. Because it's all very well to have a good document, to have a good constitution, but where the rubber meets the road is how well is this constitution being implemented. And it shouldn't just be implemented when it comes to political aspects. Here we are talking, where the young girls, the women, women's rights are being violated. How is the government responding in terms of ensuring that those rights and do not just remain aspirational, do not remain decorations in our constitution, but they actually are able to say, yes, I went to this hospital and I can attest to the fact that there's this improvement, there's more access, there's, things like that. So that's the role of the court.
Yeah.
And of course, where the rights have been violated, people have been able to come and the courts have spoken to those issues.
Yeah.
In various cases.
And I would like your closing comment so that we can do that with everyone else. What is that one action that you'd like to see government take to ensure sustainability and lasting impact, Honorable Age Justice?
Well.
And your government. So.
Okay, I'm government. Okay, mimi ni government. Now I'm on the spot. Yeah, as I was coming here, I didn't think you were going to put me on the spot as being government. But what I can say, the one thing that I would want government to do is to put in place policies that ensure that women and girls are able to access their sexual and reproductive rights, and not to claw back on what we already have in the Constitution. That we really must remain vigilant. There's always that possibility that this right is open to discussion. It shouldn't be to have arrived at the having it in the Constitution. I know the discussions that went on. I don't think that at this time in our history we should be talking of clawing back on some of these provisions in the Constitution. They have to be protected, and I think it is the role of the court to protect that right.
Thank you. Dr. Kuya.
Thank you very much, because it's always a very interesting question. But I think from my end, there's another layer that we haven't spoken much, and which is also the pushback against SRHR work. We have a lot of political resistance, cultural resistance, and all those things happening within our community. So we must really pick a very multi-sectoral approach when it comes to driving this kind of change, because at the end of the day, SRHR also has to be defended, both from a normative perspective, but also from an institutional perspective, and they go both in hand. So and I'm very impressed actually with all the government stakeholders here, from the counties, the national. I think the DG spoke well and reminded us that we cannot ignore SRHR, because for us to achieve this long-lasting change that is very transformational, we have to combine all those components. And the religious leaders are also quite important in this conversation, because they are in the communities and they need to support also this ongoing work. So for me, I think I will try and summarize there. Thank you.
Ms. Koronya, what is that one action?
The one action which I'm asking Dr. Bashir, is the government representing the Minister of Health, is that Kenya, before devolution, was 100% funding for family planning commodities. So my request to the government of Kenya is to ensure that now that most donors have pulled out, it is to ensure that the government goes to that level of funding commodities 100%, and also prioritizing family planning as a strategic program in Kenya, just like other programs, so that we do not lose the gains which we have made. So many countries look upon Kenya to really learn. They come to learn. They get so excited. We do not want to lose the gains we have made. So 100% funding of the commodities by the government.
Thank you so much. Ms. Wandia.
Thank you. I'll cheat a bit and say that I would urge the government to listen, to partner, and to fund. Listening especially to adolescent girls and women, and listening to their lived realities, and ensuring that their voices really shape the programs is very, very critical. And then partner, because sustaining impact requires coordination between national, county, civil society, development partners, and communities, and fund. Ensure that planning and policy commitments must be matched with predictable, sustained domestic investment, because we know transforming the health system will not be a sprint. It is like a relay race, and so sustained financing will ensure that the baton is not dropped. Thanks.
Thank you. Julius.
Yeah, I think this initiative is key to us realizing our demographic dividend, which has been talked about very much. I would say, how do we incorporate and make part of the system models that reach young people beyond the health facility? How do we reach young people beyond the health facility and make that part of our health system delivery? And then to our county counterparts, because this is going to go to the ground, let's go to the ground. Kwa sababu, kwa grao vitu ni
different.
Yeah, thanks.
Asante sana. That's Julius Mbeya, the co-CEO of Luala Community Alliance, Ms. Mary Wandia, Regional Director, Africa Co-Impact, Dr. Johnson Kuya, Senior Policy Officer, Strategic Partnership and Gender, Embassy of the Kingdom of Netherlands, Ms. Coronya from UNFPA, representing Dr. Pilar Molina, the Deputy Country Representative, and Honorable Lady Justice Jane Onyango. Asanteni sana, tuwapigie makofi as they take their seats. You can take your seats. Asanteni sana. And I think our panelists have done a good job to ensure that we're getting insightful thoughts about why this initiative is so important, why it needs to be sustainable, why we need to collaborate to align and to strengthen systems. And at this juncture, and I think we've heard so much from everybody else except the adolescent and young women for whom this project is for, right? So allow me to welcome to the stage Leila Abdul Khair, who's the CEO, Youth Voices and Action Initiative. Leila, karibu sana. Tumpigie makofi. She's representing those who have brought us here. Karibu.
Is it good afternoon or good morning? Good afternoon, everyone. All the protocols observed. My name is Leila. I lead at Youth Voices and Action Initiative. It's a grassroots organization based in Coast Kenya. And I'm also a young person and a young advocate from Reproductive Health Network. And I'm here to just to carry the voices of young women at the Coast region. And I want to just share about today's on how we are able to launch our health initiative. And we are here to ensure that adolescent girls and women voices are not just heard, and they are just felt. So I want to also acknowledge the Ministry of Health and also the commitment both from nationally and also at the county level, and to when it comes to adolescent health, that has laid a foundation upon of what we have built. And this initiative is not just a replacement of your work, but it is an implication of what we are being able to do it. And I want to go to the reality when it comes to costs in relation to Tana River. And with my fellow speakers who are here, and I don't know how many of you that you have been able to be in Tana River County. You have been there. And I've seen my friends here, Hawa and the director, and I just want to take you through of what Tana River is. And Tana River is actually a county in Coast Region, and it is actually in the land of Tana, and it's actually a county that has, it's arid and pastoralist county, that is mainly the agro-pastoralist county, that mainly consists of communities from Pokomo, Orma, Wardei, and different community that they live there, that they usually have a lot of struggles. And in Tana River, it's actually a home of more than 380 people who are mostly young people. And in terms of how the young people who are being able to dream about their future. But I want to go back to the reality of a 16-year-old girl coming from Tana River, especially in Madogo. And because a young girl coming from Tana River, especially in Madogo, the future of this girl is actually often to a lot of barriers, because this girl who works in a long distance health facility, if she gets there, she actually prays that the healthcare worker is actually kind to her, that the medicine or commodities are in stock, and that she can be able to afford services. And this young girl, she has actually heard about HIV, and 35% of her peers actually have a lot of stories about HIV. And when she heard about contraception, only 1.3% of these girls at her age actually use it. And when it comes to this girl, she usually gathers a lot of courage, and sometimes when she wants to ask for help, her response, especially when it comes to the community, there's a lot of judgments. So we had a lot of discussions with these girls, and one of the girls actually told our team that we are actually scared about condoms and pills at the hospital, because they will ask us about who are we sleeping with. So this young girl actually prefers to stay silent in that situation. So you can imagine staying silent leads to teenage pregnancy. Staying silent actually leads to unsafe choices, and staying silent leads to school dropouts, and staying silent leads to early marriages, and even FGM actually leads to her body autonomy that before she understands it. And sometimes we are looking at this girl it's not about her failing, it's about the system failing her. So when you think about this girl, we are looking about the walls and barriers that actually holding her back. So when it comes to lack of information, we actually ask ourselves, how can she make choices? Only 35% of our generation understand comprehensively HIV, while comprehensive reproductive health education is whispered and not taught. So when it comes to limited access to affordability, even if the services exist, even if the hospital exists, there is a lot of hidden cost complication, because this girl has no income, has no job. There is a lot of cost complication when it comes to transport for her to be able to access that facility, to access services. And most of these services are actually very unaffordable for her. So when it comes to systemic barriers and norms, we've seen a lot of weak implementation of policies, especially at the county and national levels, is a barrier when it comes to access to these services. So when it comes to also declining in terms of the donor funding and the slow domestic replacement of the outreach programs, it is actually cut fast. And the deep-seated in terms of the cultural norms when it comes to the young girl in Tana River, most of this girl, her health is not a priority, but it's a priority for her husband, it's a priority for her father, it's a priority for her brother, but it's not her priority to be able to make informed decisions about herself. So we are here because the change is actually possible. And through her health initiative, it's actually designed to be able to dismantle these walls, and with the great partnership with the Reproductive Health Network, with the ministry, in terms of how they can be able to dismantle these walls. So We recommend actually the Ministry of Health and the County Department of Health to prioritize adolescents' health and policies when it comes to service delivery. And we must strengthen these efforts together. So to our actually development partners and governments and every stakeholders here, let's continue to invest in our health. When you talk about investment, we are talking about the systems, we are talking about to make health to be sustainable. We invest in policies and financing and supply chain, and the young champions that are actually on the ground and the young people who are actually on the ground. And on behalf of adolescent girls and young women in Kenya, specifically coming from Tana River, Garissa, Homa Bay, Samburu, and West Pokot, and I want us to be able to say that we'll be able to provide the learning and document our realities, and also document our successes and failures. And we will be able to show what actually works and what it doesn't, and to be able to build our voices as evidence. And we will be able to use our stories to shape the national policies. So it's actually a lesson to see how we can be able to transform our nation, and also being able to transform adolescent girls and young women. And let's continue to invest in adolescent girls and young women, especially when it comes to sexual reproductive health. And thank you so much. Yeah.
Thank you. Thank you, Leila Abdul Khair, for those powerful reflections. Ladies and gentlemen, we now arrive at the highlight of today's program, which is the official launch of the Her Health initiative. And I would like to call the following people to the stage right there at the corner so that they can lead us in this launch. Dr. Bashir Hassan, Director Family Health. Dr. Isaac Hassan, Director Family Health. Dr. Mohammed Sheikh, Director General NCPD. Ms. Mary Wandia from Co-Impact. Nelly Munyasia, RHNK. Elsie from CRR. Mala Tabot from IPPF. Charity Koronya, UNFPA. Dr. Johnston Kuya, Netherlands Embassy. And executive directors from partner CSOs. Karibuni sana. They will lead us in the launch as the choir is also preparing for the project theme song. Dr. Isaac and Dr. Mohammed Sheikh, take it away. The floor is yours. Hi, let's count down. 5, 4, 3, 2, 1. And there you have it, the Her Health project officially launched.
ndani na kimataifa kote Kenya. Kuza maisha ya wamama kote Kenya. Kote Kenya ukame, huduma bora zipatikane. Wasichana wetu, vijana wetu, kina mama wote, huduma bora zenye heshima. Wasichana wetu, vijana wetu, kina mama wote, huduma bora zenye heshima. Huduma bora zenye heshima. Huduma bora zenye heshima.
Makofi. Thank you so much, Tom Kaoya and NCPD Choir, for that project theme song. Asanteni sana. And we are now at the tail end of our launch today. And I would like to invite the vote of thanks, which will be done by Dr. Jackie from the Ministry of Health. Lucy Kimondo, who's the Director of Public Education and Advocacy. Lucy Kimondo, karibu sana for the vote of thanks. And once she is done, we will remain seated so that our VIPs can leave. The rest of us, please remain seated. There is one wonderful skit that you do not want to miss. Asante sana. Lucy.
Thank you. Riding on the previous protocol, I just want to deliver the vote of thanks. First, we want to acknowledge the goodness of the Almighty God for the gift of a good day and good health. Nobody has been rushed to hospital today. We planned, God made it happen. We appreciate our chief guest, Dr. Amoth, for honoring and delivering a wonderful and reflective speech. Dr. Mohammed Sheikh, DG NCPD, we appreciate you for the role of making this event possible, working in the front line and behind the scenes. Dr. Bachili Isak, we cannot forget you read the family health where this square lies. We also appreciate the RHNK board for the support of this initiative that will go a long way in empowering our adolescents and young women. We acknowledge and appreciate our participants from the 5 Her Health Initiative, the county commissioners, the county directors of health, the county reproductive health coordinators, county adolescent and youth focal points, and the national regional population coordinators. You are our leads in the county, and with you on board, this initiative will go well to achieve the expected results and impact. Our panel, we cannot forget you. You have given us food for thought. We appreciate the UNAIDS for being here, Dr. Richard Amenya, Mrs. Charity Koronya from UNFPA, and the National Council for People with Disability, KMTC, Kenya Health Federation, KLRC, Co-Impact, IPPF, Loala Alliance, TICA, PSS, SIF, IPAS Africa, AMREF University, CPHD, ICLW, Obuyansi Foundation, Amplify Girls, the Youth Voices, Midwife Association, Religious Leaders, and any other organization that I may not have mentioned feel appreciated. Chief Executive Officer of organization who joined Nelly in this wonderful initiative, many thanks for honoring our invite. The young people, the NCPD Corporate Choir who have entertained us. Yes, they have educated us. Thank you very much. The 4th Estate, With you, I know we are going to go a long way in popularizing this initiative. The management of Ladison Brew for the hospitality. Last but not least, the people who work behind the scenes, from RHNK, the CRL, and the NCPD family. Thank you for working behind the scenes to make this event happen. Thank you and feel appreciated, everyone. Let's clap for ourselves. This way, this way, this way, this way, this way, this way. Thank you.
Asante sana, Lucy Kimondo, bringing us to the tail end of our launch today. And as we come to a close of today's programs, we are reminded that meaningful change happens when vision meets action and partnerships are guided by shared purpose. Mimi naitwa Mashirima Kapombe. I've been your MC today, lakini tutakutana saa moja kwenye Nipashe Weekendi siku ya Ijumaa. Asanteni sana. We will allow our VIPs to walk out. The rest of us, please remain seated. Maono Group, the stage is yours. Karibuni. Maono Group. Maono Group. Maono Group, karibuni to the stage.
Hapana, Alex, unajua kuna mipaka. Umerogwa. Hapana.
Hiyo ni kono kwa makwapa.
Kuna nini?
Efanya hivi. Mayo. Mada amerogwa. Hizi ni?
Nitamia mimi unaniambia hivyo, Alex. Mbona unaniambia?
Hey!
Alex,
Mada kamuone.
Alex, niko na nini?
Hii red ni nini?
Niko na.
Hii nini ya red? Mada. Mada. Umerogwa.
Hapana.
Umerogwa. Acha na mimi. Songa.
Amerogwa na nani na?
Unataka kwa makwapa.
Angalia kitu. Niko na hapo. Mama. Sasa nywele zikimea hapa kwa makwapa. Hiyo ni kurogwa.
Na hizi.
Na nini mama? Fanya aje Alex. Fanya hivi. Nenda huko nje. Uendelee kucheza, sawa?
Ako sawa?
Wewe.
Amerogwa.
Wewe na nywele hapo amerogwa. Amerogwa mama. Mbona hizi ninatoka hizi vitu? Rusi. Unalia nini hapa kama mtoto mdogo? Na hii angalia. Hizi ni video sana niambia nimerogwa. Si ni video hizi Rusi. Yaani mtu mzima. Wewe sasa uko na matiti. Umeanza period, alafu unaniambia hapa, ona nimerogwa. Kwani wewe una akili? Period ni nini? Yaani ninapeleka ng'ombe shule. Mama, nachukua pesa yangu Rusi na kupeleka shule. In fact, wacha nikwambie Rusi. Kwa kimila yetu, the moment umeanza kuona periods, wewe ni mwanamke kama mimi. Sasa kitu yenye nitafanya hivi. Kuna mzee mwingine anakuanga anataka pipi. Hapana. Huyo ndiye anakuoa. Hapana. Rusi, uwezi nyumba ni yako ama ni yangu? Hapana mama, siendi. Hatuwezi na unaweza kama na wake wawili kwa nyumba moja? Huwezi. Sasa wewe ni mwanamke, mimi ni mwanamke. Hapana. Uende ukae kwako. Mimi nibaki hapa kwako. No, siendi. Hapana mama. Usilize. Enda ufanye aje? Enda uoge, utafute godoro. Uweke. Alafu tutaona vile tutafanya Rusi. Hapana mama. Rusi, enda uoge. Hapana mama, nimerogwa. Yaani mtu ameanza period ya kiachu na mpeleka shule. Kwani walimu wanafanya kazi gani? Wanataka mimi nianze kufunzana. Niwape pesa patara wafunze, tena nianze kufunza. Walimu watoke wakule lunch, waende break na wasifunze. Weekend watulete watoto. Jioni wawapatie homework nimsaidie kufanya homework. Tena mambo ya mwili mweleze. Anyway, ametosea kukua pipi. Anaweza pata mimba. So kitu yenye nitafanya, kuna msee mwingine hapa anakuanga na ng'ombe 15. Nikienda niongee na yeye nimwambie kuna kasichana kangu kametosea, hata kataa. Yeye itia si mbaya hapa Itagwe. Aende anirete ng'ombe 5, rusi. Ng'ombe yende huko, ng'ombe zingine sikuja hapa. Kama hizi sika kitu surani nini anaenda kufanya anyways.
Na mpaka saa hii kwani hajafika? Ai, kwani bado hajafika? Kwani saa ngapi? Oh, my love, my beautiful, my angel, my world. Si unajua tu venye mimi wanakupenda.
Acha mimi nakupenda baby.
Mimi nakupenda tu. No, I can take a bullet for you. I can take a bullet for you. Mimi, I swear, hata saa hii ukitaka tuende tuone wazazi wako, naenda. I swear, naenda. Ukitaka tu saa hii. But si tunaenda kufanya hivyo.
Aje?
Kwani tulikuwa tumuongea aje?
Hapana.
Ai, hapana. Si unajua nakupenda. Na imagine niko ready.
But leo like oh no.
Imagine si unanipenda. Si unanitrust. Si unaelewa just once. Si ndio? Sawa, si unanipenda? Enyewe Mungu ananipenda.
Yamefanyika? Tapika mama mwenzangu. Tapika.
Sivyo mama.
Nini hivyo?
Nasikia ni kama niko na malaria.
Uko na typhoid. Yes. Uliamua, si ndio? Nikakwambia nikutafutie bwana ukaamua kujitafutia. Ni sawa. Anyway kitu ya maana ni umejitafutia wewe mwenyewe. Sasa kitu yenyewe kuingia uko ndani, chukua mizigo zako, uende kwa bwana.
No, please mama usifanye hivyo. Mimi siende kuolega.
Usini kikasirika. Usini kikasirika. Nitakutoa kitaikuondo. Nikutoa Chinese. Rusi, wacha nikuulize. Wacha simama nikuulize. Saisi uko na mimba? Saisi naweza pata uko na HIV AIDS. Rusi uko na AIDS. Rusi saisi utapata uko na nini gonorrhea. Rusi saisi utapata umebeba kaswende. Rusi enda. Rusi nisike. Nipatie magonjwa. Rusi toka. Toka. Enda kwa bwana. No. Piga Rusi. Enda. Uliamua. Sikuizi uingie kwa nyumba, urudi usiku. Rusi toka. Rusi takusuanga. Toka. Enda mwana kwa. Ufuate. Nikakwambia vizuri. Wacha nikutafutie James. James at least yako na ng'ombe ukakataa. Ukaenda kufuatana sijui na kina Peter. Sijui ni nani. Wacha hiyo Petera kuruke kijesu. Ndio utachua. Alafu rudi hapa kwangu. Kwangu nayo ukai, hatuwezi kawa mama wawili. Hatuwezi kawa mama wawili kwa poma moja. Hii ni poma yangu. Sikupelekea mamangu mimba na wewe utaniletea mimba kwangu. Si hata baba yako akichua ataninyonga. Atasema mimi hata ndio nimekupatia hiyo mimba. Wewe au kai kwangu. Rusi. Sasa nikwambie ukweli.
Na wiki 2 zimefika sijaonana na yeye. Kwani alienda wapi? Ai. Hapana. Ni nini unalia? Yes. Nini niambie nini unalia?
Sijaona period zangu for the last 2 weeks.
So kama hujaona period zako mimi unaniambia nifanye? Ni unaniambia nifanye?
Hapana, unajua I think lakini niko na ball.
Ati uko na ball? Hata kama sijui hiyo Kiswahili hiyo ngeli iko hiyo ball iko katika ngeli ya C ya nguu. Wewe toka hapa. Toka. Tulikuwa na nani? Tulikuwa na nani? Wewe toka hapa. Toka. Nimesema utoke hapa. Toka hapa. Wewe usiniite babe.
Okay, please.
Jina langu ni Fred.
Nini hapo?
Sitoki babe. Huyo ni wa babe. Toka hapa. Niko na ball. Mimi hata bado ni mtoto mdogo, siwezi peana mimba.
Turu. Acha nikupe udaku. Nipe uongo. Wacha nikwambie. Tunakumbuka ule Mili. Mgani huyo? Mili ule msichana mjui. Wa hii kijiji yetu moja. Akafanyani? Alipata mimba, akajaribu kutoa, akakufa. Imagine. Na uliona na Yakob. Ule mwenye anajificha nyuma ya ile nyumba yao na ule mzee. Na hiyo maringo yote. Huyo mzee niliambiwa kwa
Jamani madada nini
nawe? Shida yako.
Sawa basi tuseme.
Niambie mwenzangu Turu, niambie. Nakwambia sasa nasikia kuna malaria. Malaria hiyo moja.
Kwa mama wenzangu nimemalizwa. Nimeisigwa.
Ni nini? Rusi kafanya nini?
Rusi amenimaliza.
Ajiwa ndege?
Ndege anatoa wapi?
Amekufa.
Rusi ameamua.
Ameamua nini? Nini? Ako na mimba. Ulijiona wewe ndio umepata, kumbe wewe ndio umepatikana. Kabisa unakwenda na Maria. Amebeba laana tupu.
Tulieni niwaambie.
Nini nawe?
Wacheni niwaeleze, sawa? Kuna this organization, sawa?
Gani hiyo?
Gazita RH.
Wewe tutaongea na organization. Anambia mimba. Mimi nataka utakuja mimba.
Hapana. RHNK.
Imefanya nini?
Hii inasaidia wasichana, sawa?
Fanya nini?
Wanasaidika kama
sasa nitampeleka huko Voice na yeye.
Hapana, hiyo ni mtaangu amebeba. Akatoa hiyo mimba. Nipeleke wapi? Tunaenda hospitalini akatoe. Atubebe ile anatupiga.
Mama kwa mimba.
Tembea. Natutia aibu wewe. Uwezi kuwa miguu yako. Wewe nini? Tufanyani.
Security.
Tufanyani. Tumekuja hapa na mashida zetu dada. Hatuna wakati wa kusikiza. Huyu msichana anatutia aibu, tunataka toe hii kidume.
Nyamazeni. Hii ni hospitali. Tunachuana maana na protocol. Hii ni hospitali. Kuna sheria. Mmepanga laini ambao mmekuja tu na hapa na viere.
Si tumekuja atoe mimba. Atuhusu nini?
Wako na kerere. Toka nje.
Niende wapi?
Security.
Pole basi.
Security.
Pole.
Toka nje. Enda.
Naenda. Nakuachia hospitali yako. Lakini hiyo mimba kaitoe.
Security.
Nitaenda hata na hajatolewa mimba.
Mimi ni mama yako wako. Enda.
Si sorry
Fuate pia.
Fuata mimi.
Kimbelembele galifichi. You're so illiterate. Illiterate. Nyamaza. Ongea kile nani? You're so illiterate. Unapiga kelele, mnataka kuniamsha wagonjwa? Ama mnataka kuamsha waliofariki? Si hata huyu ndio tunataka nini? Kuna Kenya tunataka kuferea. Nyamaza. Amka. Songa huko. Songa. Shida ni gani? Sasa iko hivi. Msichana wangu. Songa huko, madam. Na usinifanyie nyenye. Usinifunze kazi kwa ofisi yangu, songa. Sawa. Daktari, shida ni gani? Huyu msichana wangu ni 16 years.
16 years?
Ako na mimba.
Msichana wa 16 years and you're pregnant.
Sasa acha na hiyo.
You're so stupid.
Very stupid. In fact, acha nikwambie. Nilikuwa hapa nini? Nataka daktari, mumwe kitu.
Unataka tufanye mtoto abortion? Nani alikwambia kwa hospitalini tunafanya watoto abortion? Tena huyu ni mtoto. Ni wewe una make a decision.
Si mimi ni mama yake.
You're so illiterate. Na wewe msichana wa 16 years. Unafaa kuwa una focus na vitabu vyako. Unaenda you're doing your things uko na wanaume.
Excuse
me. Acha nikwambie ukweli. Huyu naye nimemwambia usione sana kifuniko.
Mama, excuse me nurse. That is not the way to go about it.
Unakuja kunifunza kazi kwa ofisi yangu.
Sometimes it is better to listen more and talk less. Sawa?
Ongea.
Yeah. Actually, my name is Rose Wamboi. Sorry, si judge introduced. I'm an advocate of RNHK and I'm in partnership with the hospital. Na nimekuwa pale nikasikiza all the conversation that you people have been talking about. Young girl, umesema uko how old?
Ako 16.
16
na ako na mimba.
Ako na mimba. Sasa hapo ndio sita.
It's okay. Si vibaya.
Hakuna it's okay na mtoto na mimba.
RNHK imekuja hapa kwa sababu ya wasichana wadogo kama hawa. Sawa? And iko na vitu mingi sana tunaweza taka kufunza watoto wenyu wadogo. Sawa? And actually today tume launch a project called Her Health. Her Health. Yes.
Sasa ngoja niulize. Hiyo sasa inaingililia wapi na huyu na mimba na kutolewa mimba?
Mama. Kupata mimba haimaanishi ni mwisho. Sawa? Sio mwisho wake. What you'll do, mtaenda mningoje pale, nitakuja niwachukue tuandamane na nyinyi hadi kwa ofisi zetu and then mtaelezwa mengi kuhusu hayo. Sawa? Aya, twende.
Na ufunze mtoto wako adabu.
Nurse.
Tangulia unataka kunishika vile ulikuwa unasikia jina boyfriend wako.
Nurse. Sio hivyo unastahili kutreat watu, sawa? That is not the way to go about it. At times it is better to provide counseling for young girls like them, okay?
Sawa, nimesikia. Nimejua makosa yangu na nitarekebisha.
Haya, fanya hivi. Nimekuja kuona mkubwa wenu. Unaweza nipeleka kwa ofisi yake?
Haya, umenisamehe.
Nimekusamehe. Haya.
18 years later.
Joy!
Masi! How are you?
Kwaje?
Niko poa.
Uko poa?
Niko poa sana.
Imekuwa siku moja.
Sana.
Bide, mi pali niko ni utank mam wako kwa vitu ufanya by the way. Kama si mamako kukuweka, hatungekuona hapa. Unaona? This product, kama si mamake kumweka, hatungewahi muona hapa. Unaona? Now we thank all the mothers kwa kukipoto ikawa. Na tunasema tu sana kwa mothers wote kwa kutuweka kaa sisi. Kama si hao hatungekuwa mali kama hapa. Na pali moms wote wako, by the way, thanks for keeping us. You kama si nyinyi hatungekuwa mali kama hapa. Thank you so much.
And that is our journey as Maono Theatre Group. Thank you.
Asante sana Maono Group. Karibu na wewe utaona kijikaratasi kama hiki. There is a QR code. Please scan it and give feedback about how the Her Health Project launch was. Share your feedback with us. Asanteni sana, mnakaribishwa lunch. Karibuni. As you leave, please ensure you pick a meal card from the RHNK staff. Please do not go for lunch without your meal card. Asante.
imepita 10, lakini nikiwaza hiyo kitu inafanyika, inaonekana kama yenye imefanyika jana. Inakuwa ni huzuni sana. Yaani mimi tu ndio huyo naonekana the whole world nikifanana hivi. Nilikuwa nimekata tamaa, sina wa kunisaidia, mimi niko tu peke yangu pale. Hapo nilikuwa naona tu mauti. Kukaambiwa ya kwamba ukisikia uchungu iko imezidi, ukuje uingie huku ili wakushughulikie. Nikienda ninafukuzwa. Nilishindwa kabisa na nikaanguka kwa floor. Nilijaribu kuita, hakuna nasi aliyekuja. Fahamu kurudi nikisikia kelele nurses yao wanagombana, ni vita hapa chini. Nikalazimishwa nibebe huyu mtoto, nikalazimishwa nitoe hizo vitu zenye ziko chini.
The Tuesday night expose by KTN of patient negligence at the Bungoma District Hospital revealed how nurses at the hospital stood by and watched as a woman in her last stages of labor wriggled on the floor with her baby halfway out.
Josephine's case is an example of the abnormal that has been normalized in healthcare system. It is now called obstetric violence. When the rights of those who are seeking care are violated, nobody wants to subject herself to subsequent violations, so then people avoid seeking healthcare. It then defeats the whole purpose of then strengthening the health system. And the worst of it all is that it is a gross violation of fundamental human rights. It is indignifying. It is discriminatory.
Josephine was lucky because she had someone who is aware about her rights. But many people don't know their rights. So even when they are abused in the hospital, they never report, they never do anything. Patients' awareness, rights is one of the SOPs in government and private hospitals. But now, people to adhere to those rules.
Court of Appeal has added more weight to the decision of the High Court, saying that it is the responsibility of both national and county government to put in place systems, policies, structures, and protocols that will guarantee every woman seeking health care, including maternal health care, that positive experience. And for us, that is the value that has come out of the 10+ years of pushing for this case.
Kila mara nimekuwa nikienda kotini nikisikia mzuri. Nilikuwa at least nataka hawa nurses walio na tabia ya kudhulumu wagonjwa wajifunze kwa kitendo kilichotendeka. At least wafanye nini? Warekebishe. Sababu watoto wanaozaliwa ni generation ya kesho.
I think after that, a lot of change happened to nurses and midwives, and also I'm sure even the mothers have seen the changes. The only thing is to make sure the attitude of healthcare workers change to the better, to love their patient. and show them empathy in whatever situation, whether she's clean or she's dirty, whether she has resources or not.
Ningepoteza maisha, ningekuwa nimesaulika. Hata huyu mtoto wangu labda ningempoteza. Singependa mtu mwingine apitie hali kama hiyo.
You could take the case of Josephine Majani and situate it in Tanzania, Zambia, Malawi, Nigeria, and you will find the same case of girls or women experiencing undignified treatment during pregnancy or childbirth. It reveals several systemic and structural challenges that we continue to experience in the continent. First of all, it reveals that there are legal, policy and administrative gaps. Secondly is the lack of prioritization of healthcare services. This at two levels. One is the financial allocation that is increasingly limited, thereby affecting commodities at these facilities. And number two is the attitudes of the healthcare providers who are increasingly violating or perpetuating the mistreatment and dignified services to those women and girls. Third are the weak accountability mechanisms when these violations occur. The Court of Appeal in Kenya restated that maternal health rights are minimum core obligations of the state. What does this mean? It means that the African states, including the mechanisms for addressing human rights violations, need to have constructive dialogue to address the increase of maternal health violations in the continent. Finally, as the Center, we remain committed to ensuring that we call attention when these violations occur. We are committed also to working together with our partners, civil society, including member states, to be able to expound on norm standards that will address questions of maternal health rights in the continent for the benefit of our women and girls.